The first person we're going to start off with right now is Dr. Harry Goodman. As we've said before, he's the director of the Maryland Office of Oral Health. So Harry, if you'd come on up here and tell us what you've got to tell us.
Welcome and good morning, and I think we're going to have a tremendous day today. I'm basically setting the tone, I guess, with some data for I guess what's going to be the main part of the discussion today, and certainly a main thrust, I think, of what we'll be discussing is adult oral health. I know there's going to be a panel later on to discuss this as well. I don't know how many of you are familiar with Lumosity, the app, but sort of the brain tease, but I've not had the opportunity to use it this morning, so I hope I'm fairly coherent. I drove down from Harford County this morning, so we'll do the best I can. So I'm going to talk first about our success story, which is kids, and basically tell a little bit of a story. And the reason I'm telling the story is that if it could work for kids, it can work for adults. And we have to aspire to higher goals. And even when it doesn't seem like it's possible, it is always possible. And I think back in 2005, 2006, this is where the state was at that point with children. We were really, at one point, in fact, in the late 90s, we were 50th in the country in access to care. And it looked pretty hopeless. And yet, there were folks who were always had their eye on the prize that we can get something done in Maryland. Of course, it unfortunately took a traumatic event to galvanize everyone's attention to the issues. But as you can see, oral health really was not on the big stage at all, both at the state health department. We had many local health departments, but not enough providing dental. Our Medicaid program at that time was basically not serving the dental providers to a point where they were paying you properly and certainly paying you in a timely fashion. You'd pick up the phone and you wouldn't get a very friendly voice, and things would not get resolved and what have you. So there was a lot not happening with oral health, and there were certainly no partnerships. We didn't have a state oral health coalition at that time, and really we just weren't on the same page. And I think that's when we started to do it, when we started to work together. And I think that's what has made Maryland so special, is we've been able to kind of develop a sense of urgency and coalesce our efforts around oral health at all levels. And it's just amazing what we've been able to do. So we started to plan for the plan, basically, and we did a number of things and a number of programs that started to happen back in the early 2000s. A small group would which included at that point the MSDA executive director, Elza Dunning. We would just discuss issues and never let it go in terms, even though it would sometimes seem very dire in terms of what we were trying to accomplish. And so we developed sort of a legislative route, and we went to Annapolis, and we developed a number of policies that really began to help us, and the state did start increasing access to care for children. You can see some of them. And of course, we also had an oral cancer prevention program for adults, and I'll talk a little bit about oral cancer toward the end of my talk. And we even increased Medicaid dental rates a little bit. Not enough, but a little bit to start, again, gaining attention to the issue. But again, while access improved, it was still too low. Only really a small percentage of those received a dental preventive or restorative service. And really only a small proportion of dentists participated in the Medicaid program. And we didn't have Access to Care Day back then. This is our 7th one. And actually, Access to Care Day started about the same time we started to all talk together. And I've always been indebted to Bill and to MSDA for putting this program on. And it started off pretty small. And now, it's become a major event at the annual meeting. So, of course, this is, we all know this child, and this was the event. This was the traumatic event. It galvanized everyone's attention. It developed a sense of urgency, and this is certainly not what we profess to happen again. We don't want this to happen to an adult, to die from a dental infection, and yet there have been some adults I know there have been a few cases in Ohio who have died from untreated dental infections. This is not what we want. This is not the event we want to wait for, but this is unfortunately what happened. And this, of course, was traumatic and you know, really unacceptable, because this child not only lacked access to treatment, he lacked access to prevention and education that all our kids should have access to. We know how to prevent, for the most part, oral disease. We're still learning, but we know for the most part how to prevent oral disease, and yet that information was not getting to a number of children, and certainly galvanized by Diamante Driver. So after that, really the state took this very seriously. This was the event. And really what it did, of course, the then Secretary of Health, John Colmers, convened a Dental Action Committee. And the Dental Action Committee developed a plan that really was shovel-ready. In other words, all these years, we all had been talking about what we would do if we had the opportunity and the funding. And so it really, we began to meet in June of 2007. Diamante passed away in February of 2007. And really by the end of the summer, and Jane Casper was the co-chair of the Dental Action Committee. Dr. Morgan, Garner Morgan, represented MSDA, very well, may I say, on the Dental Action Committee. And it developed a number of recommendations. And most of these were accepted. Most of these, I think, have lent to the success we've had with children. Certainly, number one was our Medicaid reforms. And not only did we increase the rates, still not enough, but at least we increased a number of the rates, especially the diagnostic and the preventive services, but we also reformed the system so that it was more accountable, easier to navigate, and just easier for both providers and the public. And we instead of having 7 managed care organizations subcontracting to 3 or 4 dental sub-vendors and just making it with different rules, different things, we established one single organization, which is DentaQuest, who became the administrative services organization for the department. The department still basically runs the program. DentaQuest runs it for them. But it has been a tremendous success, and I think for the most part, you now have a system where you get paid, I think, as soon as about a week, maybe 2 at most. You basically have, hopefully, a user-friendly voice at the other end. If not, we should hear about it. And basically, it simplified certain processes that were very, very frustrating, such as credentialing and the application and what have you. And these were all issues that were being brought up by the dental community back in the day. So when the department developed the actual contract for the new vendor, these were all taken into consideration. These were all the issues. So it's not just the rates. You can increase rates, that's going to do it to some degree, but you need all this other stuff as well, and that's really what happened. We also worked, so that's the private sector. We also grew the dental public health sector, my world. And we went from 12 local health departments to 18 local health departments providing clinical care. We started to institute services that would go to the FQHCs in the state. We truly developed a much more expanded network. It's still not 100% adequate. There's still areas in the state where we don't have an answer. But for the most part, I think a resident in every county has at least a community health center or a local health department. In the case of Calvert County, a nonprofit hospital program that provides clinical dental care somewhere in those counties. It's not perfect, but it's grown tremendously. We also created a new workforce classification, public health dental hygienists. Very important for us. And these are hygienists who work in the public health sector, able to go to schools and to Head Start programs and other preschool programs and provide services without the dentist needing to be there or to first see the patient. This really has improved access, and what the point of that is, they can provide services within their scope of practice, and then for those kids, do screening and recognize those kids who are at high risk and then refer them back to a dental home. So this is helping everybody, the kids, the dental offices, and certainly the provision of services in schools. And my office does a lot of school-based services for kids who are at risk. We target basically low-income schools, so-called Title I schools, kids who don't have dental homes. We've been training general dentists in principles of pediatric dentistry. And as many of you know, you get very limited exposure to young children, and I'm talking about children under the age of 5 in dental schools for a variety of reasons. And so a number of general dentists really, with the help of the University of Maryland Dental School, we developed a didactic course and a hands-on course to provide some training principles. And we begin our medical dental collaboration, and that was a fluoride varnish program, and I'll discuss that in a second. So again, the single statewide Medicaid dental insurance company, it's been rebranded as Maryland Healthy Smiles. Again, that's a Medicaid dental program, and that's DentaQuest. And as you can see, it basically, we also increased dental rates to the ADA recommended level for this region, which is the 50th percentile. That's basically the median fee charged by local dentists. And as you can see, and I'll show the data, 1,000 new dentists have joined in about 5 years. That's remarkable. I mean, there are states around the country that just marvel at that statistic. And that happened because of leadership all over. Certainly leadership at the health department, but leadership at MSDA. Dr. Garner Morgan and just about every president that followed him really professed the line of getting involved and becoming participants. The Hygiene Association, the Pediatric Dental Association, everybody has stepped up to the plate in this state. And that's so important and it's so recognized, and we need to continue that. As I said, the Dental Public Health Safety Net, we expanded. The dental hygienist legislation. We're still looking at trying to institute routine oral screenings in schools. It's tricky. It seems like it's easy. We should just institute it. There are states that institute it, but you really want to have an answer for those families, you know, and to try to help those families get into care once their child is recognized to have at-risk disease. And that's still tricky. We need to develop, and this is something for us to all discuss as we move forward, a case navigation system, maybe so-called dental social workers, case managers. There are case I forgot the case health, community health workers, that's what it is. There are community health workers, there's actually an association of them, who do these types of things, but none really trained yet in dentistry, and that's what we need as moving forward. That's sort of the connector between the provider and the patient, so that person will help the patient navigate the system, maybe reduce no-shows, reduce cancellations, and increase referrals to dental offices, and that's really what's needed. As I said, we've trained over 800 general dentists. We also have a program that I'm very proud of where we reimburse through our Medicaid program medical providers, pediatricians, family physicians, nurse practitioners to apply fluoride varnish to children ages 9 months to 3 years old when they come for their well child visit. And then the purpose of that program is not so much the varnish, that's great, but the purpose is that they get trained by us through an improved curriculum to be able to do oral health risk assessment, and then for those cases for kids who are at risk, to refer them to dental offices. And now I think we have enough dental offices and public health programs for them to refer to. And you can see the numbers on the screen. We also developed an oral health literacy program. It's called Healthy Teeth, Healthy Kids. I invite you to go to that website. We're really proud of it. We're just about to institute now a Spanish language campaign in those areas where we have now a much higher increase in Latino populations. And it's basically, what it is not just simple education, it's literacy, which means that we try to reach these populations in a way that they can hear the messages and process them, understand them, and hopefully act upon them. And that's done through social media, depending on the age. It's done through all kinds of media and literature. And we try to have our literature in plain language so that the language is simple, easily understood. This is still growing. It's a challenge to continue to keep growing, but it's something we're very proud of, and it's continuing. And again, it needs a partnership of everybody to keep this moving. So here's the data right now. I mean, this is as of calendar year 2012. We're always about a year behind. The new data is about to come in about a month. Right now, 68% of Medicaid kids received at least one dental service in calendar year 2012. This is compared to 34% in calendar year 2001. Actually, in 1999, when we were rated 50th, we were at 19%. And now we're at 68%. That's something everybody in this room should be proud of. And if we can do it for kids, we can start doing the same thing for adults at some point. We have over 1,800 dentists in the program versus 649 in 2009. That's amazing. And again, that was a result of a lot of efforts, but one of the big efforts was Dr. Morgan and other of the leadership in MSDA doing their dental society visitations and encouraging dentists to participate and join the program. That also is a result of this day, Access to Care Day, and Bill's work in basically promoting the program, hearing out the problems, troubleshooting, and moving forward. And it's just, I can't say how important it is. Again, as I said, I think we have at least an answer in all counties in terms of access to a public health program. It's not perfect, but I think we've done a whole lot there. So here's the data, as you can see. I won't linger on that. Also, we've now had an amazing disease outcome, and it's not an easy slide to see, but bottom line is we've reduced untreated tooth decay in Maryland by 41% in the last decade. 41%. And we just sent out a report to all our partners. We're getting, people are just marveling at this. And that's because we've improved access to care. And that's so important. I mean, that is your ultimate outcome. And this data came out in our school children survey. We do a school children survey every 5 years. We've been doing it since '95 with the University of Maryland Dental School. We just, and this is the data from the latest one. We're about to institute a new one in about a few years. Here's ER. Now, ER visits. Now, this is for Medicaid kids, and that has come down slightly, and it's actually about less than half of 1%, which is good. I mean, it's come down, and it's starting to come down. I mean, really, it should be at 0 for a child who's covered by Medicaid. We shouldn't have any kids. This should be perfectly 0. This does not include adults, and this is certainly an effort led, of course, by Dr. Romaine and others to look at getting decent, clean, understandable data for adults who go to emergency rooms. And the data that it shows, because as we all know, patients, adults go to emergency rooms and for the most part are lucky to receive maybe medications for infection and pain and no definitive treatment, and they become repeat offenders. They're back in 6 weeks, 6 months, what have you. This, as I have told Diane many, and she totally gets it, of course, and there's a national effort. The American Dental Association is, of course, pushing for ER diversion. We really support that effort, but this is where the data may really prove to be helpful as we move forward for maybe looking at adult care at one time, because it's costing the state X amount of dollars. I don't know exactly what it is in Maryland, but it's high per patient, per visit to an ER to get basically nothing done. So that does not make sense. Does that make sense to anybody in this room? I doubt it. So this is where we are on that. Pregnant women, another big issue. Now, I don't know if, are you aware? In fact, while I was waiting to come up, I got an email from someone asking about pregnant women benefits under Medicaid. And the one thing that changed when we went to Maryland Healthy Smiles is that while it used to be 60 days postpartum coverage, now it's not. It's basically the day that the baby is born. That's when coverage ends. So there's really a very small window, and pregnant women of all ages have Medicaid coverage. So it really, until you learn you're pregnant, until all the other stuff that goes on, there's really a very small window to basically provide care. And we all know through programs presented here and national programs that it's perfectly safe to provide dental care through pregnancy. So we need to, so this is something that probably needs to be looked at. But as you can see, actually access is going down for pregnant women from 11 to 12, and that shouldn't happen. We really need to be improving on that. So that's another problem, as I said, and this is an area to be looking at. And again, this is the same thing. The other one was pregnant women who are over 21, and this is for over 14. And you can see basically the same trends. It's going down rather than up, even though we've made such great strides for kids. We also, and this is of course there's also a database that we collect at the department. We don't collect it in my office, but we work with the Office of Women's Health, who collects this data. It's a CDC survey, and basically it's self-reported survey. So probably the numbers are worse than what they're showing here, but basically 40% of women in the 12 months before pregnancy had not even had a dental cleaning. That's how the question is asked. And we all know the importance of preventive care for pregnant women. 40% in the year before. 1 to 5 years, it was 28%. 7% 5 or more years, and never 5%. And of course, highest among our most vulnerable populations, ethnic populations, and those populations with less than 12 years of education. Access for adults, and I know we're going to discuss this today. Again, this is a self-reported database. It's called the Behavioral Risk Factor Surveillance System, or BRFIS. It's CDC. This is again collected by another office, but we monitor it, and we promote asking dental questions, because they ask a whole realm of questions. And as you can see, for Maryland adults, about 27% have not visited a dentist in the past year. This is self-reported, so you basically know that it's higher than that, because they often will not want to admit that they've not been to a dentist in the past year. 7% had not visited a dentist in the past 5 years. About 23% describe their condition of their teeth and gums as poor. Again, that's how the questions are asked. And about almost 29% reported ever having an oral cancer examination. So again, there's a lot to be done in this particular area. Finally, we're finally getting into not just adults, but older adults. And my office does conduct, as I said, we do a survey of children every 5 years. Well, for the very first time, we conducted a survey of older adults. And I know this is an area that MSDA and the Maryland Dental Hygiene Association have really looked at carefully in developing a pilot project. It's really important. These are our oldest citizens who are usually found in our particular survey in congregate meal sites, senior centers, nursing homes, and assisted living facilities. And we were able to screen almost 1,000 older adults. We had contract dental hygienists going out there and basically assessing risk, assessing levels of whether they need urgent care, early care, what have you. And this is this is sort of what we found, that in senior centers, early and urgent care, about 26% of the participants. And senior centers are probably the healthiest cohort of older adults. They're not institutionalized per se. Aggregate meal sites, 39% needed early or urgent care. Assisted living, 33%, and then when you got to nursing homes, 56%. And the data doesn't tell the story. And we're basically analyzing the data as we speak. We hope to have a report out in the fall, well, late fall probably. But as part of that, we're also going to have qualitative comments made by the examiners themselves. I mean, I know 1 or 2 examiners would come to me and say, Harry, I just cannot believe what I saw, because the data doesn't show the severity of these needs. They're unbelievable, and you all can figure out, what is going on. I worked in a nursing home at the VA Medical Center in Perry Point, and you had patients whose mouths were not even open for days, if not longer, and held together by dried secretions or what have you, especially those who were tube fed. It's a sorry state, and we want to live our last years in dignity, and this is no way to do it. And dental is a big issue. In fact, there are a number of nursing homes that didn't want us in there because they felt if they knew what we were going to find, and then they would feel compelled to have to do something. And so we probably only maybe some of the better centers, to be perfectly honest. So this is an issue also that we need to be paying attention to. Oral cancer is a good news story. We instituted an oral cancer prevention program back in the late 90s. We engaged our medical colleagues to begin to train them to look in the mouths of the older adults, because we all know that similar to very, very young kids, older adults also have probably the least access to care to dentists of any population group, especially those with dentures. And that's the population you most want to have seen, and to basically have the dentures taken out and look at the soft tissues. We used to have one of the highest oral cancer mortality rates in the country, and I'm happy to say now that we've really come up. We actually have a lower death rate than the national average, and as we rank about 21st lowest, which it's 21st best, in other words, in the country, as opposed to 47th or third worst in the country. So we've really come up, and that again is because of our training, getting the dental community to make sure that I know we've all been doing oral cancer exams, but doing them appropriately, and we engaged our partners at the National Institute of Health who provided materials and help. Dr. Bob Ord at the dental school, medical school, was a great help, and I think we've made great strides, and this is something to be very, very proud of. I think this is a great achievement for all of us. So we're a good news story. I mean, we're the state everyone looks to. And sometimes I go, wow, you know, if Maryland's the state that everyone looks to, it really has to be pretty bad out there, because we make great strides with kids. We have. It's an amazing story. It's a wonderful success story. But still, you know, we still have 32% more of kids to get to in the Medicaid program. And certainly with our adults and our older adults and our pregnant women, we still have a long way to go. And special needs kids and special needs adults and our other populations that require a lot of attention. And we still, we don't even have a handle on the data for those particular populations. So we're proud. This is something to be proud of. This is something that, you know, again, that we, again, there are not many states that do Access to Care Day with a partnership with the State Oral Health Program and the State Dental Association and other associations. And I'm real proud to be here because of that. We still have a lot more to get done. And that's pretty much it. Thank you.
Good morning. Thank you so much for inviting me. I'm going to condense about a 2-hour lecture into about 30 minutes. So I'm going to talk really fast. Now, and then we're going to have an opportunity to ask questions and later on during the question and answer period before lunch. This is kind of my story on how I got started in treating mostly geriatric patients. But we'll start off. Just a little bit about myself. I have a practice in North Bethesda, Maryland. Currently 5 doctors in our office. I'm on the medical staff at Rockville Nursing Home, which I'll show you pictures of in a few minutes, a 100-bed facility in Rockville. And I'm also on the medical staff at the Hebrew Home of Greater Washington, a 700-bed facility in Rockville. And I'm also on the dean's faculty at the dental school in the Department of Periodontics, but I'm a general dentist. And the interest there is Mark Reynolds, now dean of the dental school, chair of periodontics at the time, has a great interest in geriatric dentistry. As we know, one risk factor in periodontal disease is age. I like showing this slide. It kind of reminds me of the Mission of Mercy last week in College Park. But no, this is in honor of our dental school, University of Maryland School of Dentistry. This was 2 buildings ago on Green and Lombard. It's now part of the University of Maryland Medical Cancer Facility. So this picture was taken in the 1940s, and I put it up here because first you can see how far we've come in time with equipment and asepsis and things like that, but also many of our patients that we treat first that are geriatric remember these times. They lived through World War II. They remember dentistry may not being so comfortable, and so I like to show this slide. A lot of information here on this slide. This is from a study from American Journal of Public Health in May of 2004, and what it's showing is by the year 2030, 150 million U.S. population, or 1 in 5, will be over the age of 65. And they'll become increasingly diverse in terms of race, ethnicity, financial resources, living conditions, and certainly these people are going to need dental work. This happens to be my father-in-law, Tom, lives down in Florida, and they just moved to a CCRC. Does anyone know what that is? There's many long-term care. There's many different types of long-term care. People could be living in a group home, a nursing home, assisted living. A CCRC is a continuous care retirement community. You're going to hear more and more as our population ages. It's a facility where you move in and they're going to offer all services, many of your meals. If you become sick or you need rehab, it's on that campus there. If you need full nursing care, dementia. So that's a CCRC. They love it. They moved in there a year ago. We're going down next week to visit them. They're just so happy. There's social things. He doesn't have to drive anywhere. So just be aware of that. In my practice, we treat all ages from 3 months to 104. This happens to be my wife's grandmother, Miss Mary Fisher. She lived to be 100 years old in 3 months. Unfortunately, she passed away a few years ago. But we liked Rockville Nursing Home. She lived in Lancaster, Pennsylvania. We liked Rockville Nursing Home so much, we brought her down to be closer to us because there wasn't any family there at the time. And she lived out her life there. You go into these facilities and you do a dental exam, and the nursing staff, can you see another patient? Would you mind taking a look at this patient? So I met a new patient. She was my oldest patient, was 106. And she said, I'd like to introduce you to my roommate. She had all her facilities. So I'd like to introduce you to my younger roommate. She was 102. So, and just to go back, Mary Fisher here had most of her teeth. She really took pride in her teeth. She would have had all her teeth had she not gone to a Hershey Bear hockey game. And back then they didn't have the plexiglass, and unfortunately she got hit by a puck and told the story. She was taken to the trainer and sewn up in the locker room. But this is my niece Lauren at age 4. And I don't know if you've noticed this trend, but some kids are getting their teeth extremely early at age 4. So it's not trauma. She lost these teeth just as part of her maturation. So kids may be getting their teeth earlier. We're living longer, so these teeth are going to need more and more maintenance from our part, whether it's hygiene, restorative, replacement. And this shows the average age according to the World Health Organization in the United States in 2011. And also the stats for edentulous. So we see people are retaining their teeth, less dentures are being made, so those teeth are going to need more cleanings, more restorative treatment. So we have to keep that in mind. When, as Bill mentioned, I'm Legislative Affairs Committee Chair for the Maryland State Dental Association. We had a great year this past year with 2 of our own bills passed, which is, one bill passed is great, but 2. One allows us to dispense antibiotics to a patient of need who has no financial resources, a full course of antibiotics. Up till now, we could only give up to 3 days of antibiotics. So that improves access to care. We're also able to dispense fluoride, chlorhexidine now from our offices, or starting October 1st, without heavy regulations from the Board of Pharmacy. So when we look at thousands of bills that are going on in Annapolis, we look particularly as far as dentistry is what's going to help improve access to care. And I think we've been highly successful on that regard. Why my interest in geriatric dentistry? It's all innocently started about 15 years ago. I had a patient who was a charge nurse at a nursing home, and she called me and she said, I have an elderly patient here. He's very uncomfortable with one tooth. Would you mind coming in after work and taking a look? And of course I went in and did whatever I had to do. And while I was there, the staff said, would you mind looking at this patient? And can you look at this patient? And I said, well, I do have to get home at some point, but sure, I have a hard time saying no. But for me and my practice, there's certainly the need, as Dr. Goodman stated before, many untreated problems on these patients. They're generally very interesting and rewarding patients. You have to have time to talk and listen, but they have great stories to tell. They generally have multiple medical issues. Now, some people may find that challenging and not like that, but I like, pulling out PDR and looking up all the medications the patient's on and talking to them, maybe doing medical consults as needed. They generally want to please you. So they're going to try as best as they can to use an electric brush or use a mouth rinse or whatever you prescribe for them. And it's also a practice builder because you see nursing home patients, you see nursing home staff, you see the families of these patients. So for a young dentist starting a practice, it could be a real practice builder. Now, this is my office off of Rockville Pike, and the office has actually been there for 40 years. These steps are a barrier to access to care. Now, what you don't see in this picture is there's a long walkway off the handicap parking spot. They can go through this tunnel and easily access my building. So when you're looking at a location, if you're looking at moving your office, you want to consider, how are my patients with walkers able to get into my office? You want a nice, relaxing office, a waiting room with perhaps some movable furniture. So if you have 2 or 3 wheelchairs or a patient coming in a jerry chair, a jerry chair is like a lazy boy on wheels. And some patients they're just so uncomfortable, they may be in a jerry chair. So you need to be able to reorganize things. You need wide hallways in order to bring these wheelchairs through. So that's something to consider if you're remodeling. You need handicapped bathrooms on your floor, and which I'm fortunate to have. Handicapped bathroom is a stall you can do a 360 in the wheelchair in. So I find that that's extremely helpful. Rather large operatories with all the monitoring devices here. I can either transfer a patient from a wheelchair or a jerry chair onto my dental chair, or I can slide the chair over towards the wall and treat the patient in the wheelchair. Some of the wheelchairs don't have a whole lot of back support. On an ADEC chair, you can slide the headrest out, put it down in the back of the wheelchair, and give the patient some headrest support that way. Just remember, take the headrest out when you're done so you get it back. One ingredient that everyone needs is a very caring staff to everything from answering the phone for a family member or a nursing home staff that may call with a question, to dental assistants that are very versed in transferring patients, and also a special care, numbing a patient when staff persons may be holding, petting an arm and talking to the patient to kind of distract them that way. So I have to say that I'm really lucky in that regard with a great staff. You need a real good dental lab, and in this day and age, a lot of people are sending cases all over the country in the mail. But for me, if I'm doing a denture repair, that patient does not want to be without the denture for 2-3 days or a week. They need it back right away. So I have good lab technicians where I can drop it off, have the patient come in the evening, take an impression, or do it in the nursing home, take an impression, drop it off on my way to work, get it back that evening and back to the patient in 24 hours, something like that. So something to consider is a good dental lab. Now, things to consider if the patient is coming to your office. You have to be a little bit flexible because sometimes they're relying on mobile vans to bring them, not just family members. And sometimes those drivers run behind or don't know the location of your office. So you have to be a little flexible. Mid-morning appointments are best. That way you're least affecting their meals, their medication plan, and it gets them back in time for lunch. And you want to, obviously, just like all your other patients, review the medications. They're going to come usually from the long-term care facility with a rather large packet, and it's going to list all the diagnoses, the medications, so you can check that way if the patient's pre-medicated, for example. Also, one challenging aspect in geriatric dentistry is determining who's responsible for this patient. So many times I will talk, if the patient has dementia, I'm going to get on the phone with a family member and establish who is the guardianship. Sometimes the patient has no family, so then I'm talking to a social worker or the county gets involved. Some of the patients may have do not resuscitate orders. I've never had this happen, but it's possible. Patient comes to visit you, there's a medical, you take the blood pressure, there's some issues, you have to call 911. You're going to want to relay these DNR orders to the rescue squad. And then say you're doing a crown preparation on one of your patients, but they live in a long-term care facility. Sometimes it's very hard to get them back and forth, do as much care as you can, and maybe you can do the follow-up care at the long-term care facility. This is the medical order filled out by the physician on what rescue, whether the patient's CPR or not. I'm also have been called in to consult with patients. This is Casey House in Montgomery County on patients in hospice care. And that's 6 months or less to live. Now, sometimes patients will surprise you. They've been on and off hospice for 2 years. But I find hospice comes either the patient may be in hospice, or hospice will come to the patient, their home, or to the long-term care facility. And obviously, we want to keep treatment palliative, keep the patient comfortable. The case I was consulted with at Casey House, patient had terminal cancer, and she wanted to go home. Physician would not let her get home because tooth number 8 was very, very mobile. So they called me. I went in with the dental assistant. We reviewed everything with the family, took the tooth out. Patient went home, and she died a couple of days later, but she got her wish to go home. So just be familiar with hospice. I think we've all had family members that have or known someone have cancer, and hospice is a great service for those patients and their families. This is some information on living will. Again, I won't go into it in great detail, but it's when a patient's in terminal, it's deciding, do they want to be tube fed to extend their life? How long do we want to prolong their life? So you want to be familiar with living will documents. Medical consults. I'm happy to say our medical colleagues are finally catching on board that the teeth are part of the body. And I'm really honored, thanks to Dr. Romaine, I've been invited in November to the Maryland Medical Directors Association. I'm giving a presentation similar to this. So I'm going to relay to them again how important dentistry is and how we need to work collaboratively. But obviously I have a sheet, patient comes in, we don't know if they need to pre-medicate, for example, or maybe they're on anticoagulant therapy. I tell you, I don't mess around with the dosages. I'll let the physician do that. So you really need the medical consult, and often we're the first one. I've been called in numerous times, spontaneous bleeding of the gums. I go in, plaque control's pretty good. I said, well, what's the latest INR? And they'd run it, and it's way out of whack. It's 6, 7, 8. I said, well, there's your problem. So they need to get that INR, that PT, back under control. So those are some different conditions where I get the medical consult. There are, in Montgomery County, this happens to be Virginia Dental Health, is mobile vans. There are practitioners that will go from facility to facility, and they're wheelchair accessible, and they have everything on board. to provide care. Here's a picture of Rockville Nursing Home. And this is the Hebrew Home. The Hebrew Home is a really nice, they actually have 2 clinics. They're 2 high-rise buildings. And this is Maria here, the dental assistant. And it's a volunteer clinic. Practitioners volunteer. I volunteer once a month, but I also get referrals back to do dentures and things like that for patients. But that's a 2-chair clinic. In both clinics are 2 chairs. 1 regular ADEC type chair, digital radiography. It's really outfitted well. And then we have a wheelchair chair where you can back the wheelchair back and it engages. You lock the wheelchair in place and tip the patient back. I haven't yet met maybe at the trade show tomorrow, a wheelchair-friendly pantograph. It's try to get the wheelchair in here to take a pantograph just seems to be an issue, but we're working on that. And then this is the ADEC unit. Again, the room needs to be spacious enough to pull that wheelchair right next door. Now, how do you get more involved? Well, you can follow a patient. Maybe you have a patient of record that becomes ill and goes into a nursing care facility. And you could say, call the long-term care facility, say, would you mind if I come and just do an oral exam for this patient? I'd like to come visit them. But you can't just walk in and say, here I am. Many facilities are going to require applications. I can tell you that it's just like hospital privileges. There's paperwork involved. They're going to want to see a copy of your current license, references, evidence of malpractice coverage, and you also have to be willing to work with the team, and I'll show you some of the team members. This is Mr. McCubbin. He's the medical director at Rockville Nursing Home. So you would contact this person, introduce yourself, and say, hey, I'm interested in providing some care. And this is one of the nurses and the dispensing cart on your left, and then one of the nurse's aides. And one of the things I like to do is if I go in and see a lot of plaque, I'll go with the nurse's aide because they're usually the one providing the care and say, can you kind of show me how you take care of this patient? You have to work with dietary staff. It'll say in their record, and we use Point Care Click, PCC. It's an electronic record. I can remotely access it and do notes that way at both facilities that I'm on staff at. But you need to know what kind of diet they're on, especially if you're going to provide some surgery to the patient. We may have to write an order to change their diet. Many elderly patients have dysphagia, and what's really nice at Rockville Nursing Home, they have a speech therapist that's very involved in swallowing trouble. She calls me in many times for consults because she wants to rule out dental problems. And they have a special lunchtime program where a facility, a nurse or a social worker or a staff person will sit right with the patient and kind of motivate them to eat. Because if you think about it, one of the things that really hinders you is if you're not able to eat on your own, if you have to be spoon-fed. You think about little infants, well, it's the same thing with adults. If they have dementia so bad, for example, that they need all that care just to keep up their nutrition versus a patient that can eat on their own. And I mentioned physical therapy and especially speech therapy. I work a lot with them. Now, I wanted to update my slides because my staff was so nice. We went to Lowe's and we pulled DeWalt, the tool company, makes a chest on wheels with little drawers, really, really nice. But I didn't get the picture in time. But this is the back of my car, and I've got a lab engine here, I've got my supplies here, I've got gauze and things, and you really need magnification and a light. Yes, there's a gooseneck lamp in the nursing home, but there's no dental clinic in many of the facilities, so you have to bring your own supplemental light. And then I have everything in cassettes, which we open up on those patient feeding tables, unravel them, and I get everything out that way. Just to go through a few cases, Mrs. S here, she's age 89. She has a variety of health issues, including aortic valve repair. So when I see that, I don't need a medical consult for that. I just go ahead and write the order. Now, I'm not, for patients in a long-term care facility, I'm not dispensing medication. I'm writing it in the prescription orders. The nursing staff will take care of providing the medication. If a patient is transferred to my office, a lot of patients, especially elderly, was like, they didn't eat for some reason. And they knew they were coming in for dental, they just don't eat. And I said, aren't you hungry? And I give them an Ensure. I make sure I notify the nursing staff that I've given them some nutrition because that will affect their daily caloric intake. The nursing home's tracking that very carefully. But she's on 12 medications. With treatment, we pre-medicated her. We reviewed oral home care with the patient and the nurse's aide. Exam charting, just the same things you would do if the patient was in your office. Dental scaling, fluoride varnish, and I write in there a 6-month checkup at the nursing facility. And I do once a year, I do in-service with the nursing staff, especially the nurses' aides, because if their home care is not good and they're providing it for our elderly family members, chances are it's lacking a little bit. And I have been known to put orders in the chart, need to improve oral home care, and sometimes they'll call and question me about that. But I have to do it, and I have to review what to look for, how to improve plaque control for the patients. Harry's talked about fluoride varnish for the kids. Fluoride varnish has been approved for long-term care facilities as well, and we use quite a bit of fluoride varnish on the patients. WIC women, infant and children clinics, Head Start programs, school programs, daycare institutes, long-term care facilities. So fluoride varnish is a really good, powerful tool. Here's another case, Mrs. H. She has partials. She's fractured some teeth. So when designing partials, sometimes they don't have a lot of dexterity, so we try to make it retentive, yet they're able to take it in and out. So this happens to be a flex clasp here versus your traditional cast clasp here. Don't remove every root tip. Sometimes if they're not infected, I'll leave that there, and I'll show you some cases of that. Here's one case, actually on just an update on this patient. She fractured tooth 11. She had endo on it. We took an x-ray, no lesion. So why take it out? It would destroy a lot of bone here to take that out. So we're doing a locator. There's no other teeth on her upper left. So a locator is going to be a really good service to her. The denture is going to pop right in. So we're actually fabricating that. It's in the lab right now. A lot of the different things that we use, that you use on your patients in your office that may be helpful to your patients. You're all familiar with these. Toothettes. I don't recommend, I work a lot with Janet Yelowitz at the dental school. She doesn't like toothettes. I don't recommend them that often, but if you've got someone that is tube fed and they're crusted, a toothette, a moist toothette in there really helps to keep things clean. Here they put a toothette on a little vibrating instrument, and speech pathologists have found that has helped to get people to speak better in one study that I read. Where to provide the treatment? Well, you can do it right in their wheelchair. Some patients don't get out of bed, so you might have to provide it bedside. If you're fortunate enough, like the Hebrew Home, there's a dental unit there. This is the beauty salon at Rockville Nursing Home. It's great, sink, countertop. It works great. I just have to coordinate it when the beautician's not there. Arrange transportation to your office. There's just some things I don't feel comfortable doing. I may not have everything with me. So I'll work with the social worker, the family, get the patient transported, or sometimes we'll work in a surgery center. I may call in an oral surgeon. Portable x-ray, this is the Nomad unit. I just had experience at the Mission of Mercy in College Park this past weekend. A great instrument, I will say, and it's FDA approved. You have to, this is not for all applications. You can't get this in your office. Our Maryland Department of Environment heavily regulates these right now. So, but in a long-term care facility, these are great. And this is she's in her 90s. She walked in March in my office, and she said, "My bridge is loose." And I said, "Yeah, I can see that. It's flapping here. We need to do something, and we need to do it quick." Well, sometimes they don't believe me. And so she waited till Christmas Eve when I was away on vacation, and my partner had to handle this case. But the bridge, she walked in and the bridge is in her hand. But we were able to take care of the hopeless teeth. We did some dental implants on the lower right. And here's an example of a lady that's 95. She still drives. She still has her facilities. She is a tour person in one of the museums in Washington, D.C. And so she needs to speak to people. So we had to do her case rather fast. Here's a case when you look at it. So it's a nursing home patient I saw bedside. The tooth had fractured 19. The tongue was scraping against the tooth, was really raw and ulcerated. There was some decay there. It actually was not as bad as it looked on the x-ray here. But we were able to save that tooth with a large buildup and a temporary crown on it. And then we followed up with the final crown. Of course, you'd notify the family she may need root canal on that, but she's doing great. And we finished her treatment up at the nursing home. Now, I was going back over like root tips, when to extract, when not. This one had a sinus tract, so we decided to take that out on that patient. Same patient, upper arch, we did fluoride varnish on this number 7. It was an abutment on a bridge, and she kept it for about 5 years. I did extract it a couple weeks ago, but the reason I extracted it was 6, which was an abutment on a different bridge, started becoming percussion sensitive. The bridge was becoming loose. It was all decayed in there. So if I'm going to take one tooth out, I said, well, let's go ahead and we'll just section it out from the bridge and take the other one out. Real quick, this is November of last year, adult dental care for frail adults, cover story in JADA. And it presented a retrospective study that followed almost 200 residents in a nursing care facility, and they broke them down into 3 groups. And Harry's statistics were pretty good, because I heard a Harris poll that interviewed adults, and about a third of the adults in America say they haven't been to the dentist in the past year. So in the nursing care facility, that number was about half had no care in the past year. 36 had limited care, and a rather high number, 61, had typical care that they go every 6 months. And the conclusion in the study, while most of the patients were in their last year of life, so they looked at people that died, the study ended when they died, and they went back, did they have dental treatment in their last year of life? Most patients in their last year of life received insufficient care. Quite a large percentage, 61, received normal care. And it kind of got me to thinking, well, maybe if people aren't going to live, maybe we're over-treating in some cases, just the thought process going there. So the article went in to state what are some of the barriers to elders getting care. And here's a list here. There may be a lot of other medical issues. It's not being diagnosed. Limited involvement of dental professionals, dentists and dental hygienists in long-term care facilities. And then lastly, the patient's resources may be limited. So if we have a patient with a substantial health history and we want to provide just palliative care, and I discussed that option with the family, we obviously want to keep them comfortable. We want to prevent systemic disease. A big one is aspiration pneumonia. So any loose teeth, we want to clean them up, limit the amount of bacteria in the mouth, and just improve their quality of life. Maybe they can eat better. I put this picture in because not all patients in long-term care facilities are elderly. This patient's been in a long-term care facility since he was a young boy. He was hit by a car. So a lot of times it's trauma, and they're not all elderly patients. But financial arrangements need to be discussed with whoever the guardian is on the case, and financial options discussed. Many patients, I find, have insurance benefits that we want to get that information and have my staff submit that. Many of them are fee-for-service. Now, I'll mention IMEs, incurred medical expenses. Now, these are a way of patients on Medicaid getting coverage for dental services. And you have to work with the long-term care facility. The long-term care facility submits the claim. I have not gotten involved at this level. We've made some preliminary inquiries, but not. Or you might do gratis work if a patient just has no funds at all. As was mentioned earlier this past winter and spring, we did a long-term care initiative. Many groups came together. The Maryland Dental Hygienists Association, the MSDA, Office of Oral Health, the dental school. We had a dental lab. We did some continuing education, similar to what we're doing today. And then we actually did a health fair where we did some screenings and some limited treatment on patients. We did some denture identification. Here's Mr. Onick from Onick Dental Lab doing denture identifications. He brought his pressure pot right there. And I think that's crucial because I've had cases where a patient with dementia, she went down the hall and she collected everyone's denture and brought it back to her room. And you can imagine the nightmare for the staff. So start thinking that direction. Even if the patient lives at home, you're either going to have that denture for 20 years, 30 years, maybe put their name in a nice spot where it can be seen. Now, I'll mention, this is Laurie, a dental hygienist, who I just brought in my staff. She was part of the long-term care initiative, and now she's joined my staff because we're now doing general supervision for registered dental hygienists. And this is how it works. The bill was set to sunset. We just had the sunset provision removed, so it's actually been law the past 2 years, but the sunset's been removed. So this is going to be ongoing where more and more practitioners can do this. But the supervising dentist must have done an exam within 7 months, and then you can write orders in the patient's chart for the dental hygienist to see them every 3, 4, 6 months, whatever you decide. The dental hygienist and the supervising dentist must have at least 2 years of active clinical practice, must have CPR. The facility must have a written emergency plan, which most licensed facilities in the state of Maryland do. And there must be contract between the supervising dentist and the hygienist, you know, what to do if you suspect something, certainly a communication line open. And the supervising dentist must be available for consultation. So I want to thank you all. I guess our goal here for being here today is regardless of age, we want a healthy smile for all our patients. That's Claudia, one of our dental hygienists, and an elderly patient. with dementia. And I just want to thank you all so much for the time, for being here to learn how to care for our patients. Thank you.
I've kind of had a unique experience with elder care for a number of years. I work with a group. Charlie, do you have the clicker? Thank you. Which is called Villa Assumpta. Villa Assumpta is a senior care community that is run by the Sisters of Notre Dame of the Mid-Atlantic Province. This is a full nursing care facility of about 30 patients that's located within the Villa Assumpta community. Give you a little more background, we're located in Baltimore County in kind of an interesting medical triangle that this group's in the middle of, between GBMC, Sheppard Pratt, University of Maryland, St. Joseph's Hospital. We have a little bit of a different situation here because this is a very interesting situation where we are dealing with a federally funded home which is open to all women who have basically professed religious vows. In other words, 100% nuns. And so, now this is my abode. For those who don't know me, I'm Bill Martin. I'm a past president of Maryland State Dental Association. I've been working with access to care issues for a long time. And I kind of lived a comfortable life in Towson with a nice office right off the Beltway. You know, looks good, everything's great. But the first thing you'll notice is the chairs are a little bit different here. For many years, I've worked with a lot of elderly because I'm right between 5 nursing facilities. Places like Blakewood, Edenwald, everything else like that. And the first thing you find is that the elderly don't move the same. Because we do so many elderly and the patients in the office, 4 out of our 5 chairs are equipped as knee brake chairs. Reason being, elderly person doesn't necessarily bend well at the middle. And so if they can sit down in a normal chair that can be elevated to transfer them, they're much more comfortable. Interesting thing about these chairs, they are CDC and ADA approved, basically meaning if you buy these chairs, many times they get you for you're able to get tax credits because they are handicapped accessible. Might cost you $1,000 more, but then you might end up with a couple $1,000s off taxes. And so there are ways to start looking at equipment in your own office. We are equipped in the office to deal with people like Angela. Angela is a quadriplegic that we can bring into one of our wheelchair rooms and be able to treat her there. You know, it's a whole variety of people that are available to you in your own office that need care, that can pay for it, that have all these disabilities. And what we found is purely by accident, by getting the word out into those communities, we stay very busy and we get, we get paid for and we can do good quality work, and these people just need a place that they can go easily. If you can provide them that, you have a whole group of patients that you really get rewarded by taking care of. But let's talk about Villa Assumpta. This is a former convent that has been converted into a long-term care facility that is a true CCR. It has a full step down within it. And it is, as we said, run by the Mid-Atlantic Division of the School Sisters of Notre Dame. The situation I got involved with is they had a previous dental director that ran for the whole province that basically quit because he refused to give treatment to some of the people in the nursing area because it was too hard. It hurt his back. And you can't believe there are people like that out there in dentistry, but they are. And as such, I have to give a thanks to how I got recommended in here. Sister Jane and Sister Mary Frances Gipe, which are the aunts of our former president, Jane, oh geez, I'm trying to forget, but Dr. Gipe, our former president, was their aunt. And it was very funny that, you know, they came out and they said, okay, I got recommended because of that situation. I took over here as their full dental director for watching their claims and all their facilities in 2009, with my home base being at Villa. And this is the standard patient you get. This is Sister Riley. And as you see, she's got her little cart running around here. Happy bunch. And they're great to work with, but, you know, they're not mobile. You know, my average age that I see here is 90. It's a very different thing, and we've learned a lot of things as we went through all this. The ones that were truly ambulatory, we take out to our Ruxton Towers office, which is 5 miles away, because we have everything there, and it's a little bit easier to do things. But we've got a non-ambulatory group, and when I say non-ambulatory, I mean I've got vans at my proposal that can bring in a wheelchair. Non-ambulatory is really not ambulatory. You do not want this person out and in your office. To basically say everything, we came up with a plan, and this was a pretty difficult thing to say. But we talked with the sisters, we had a group, and we decided that because all of these ladies had given their entire life to religious things, that we wanted to be sure that every one of them got full dental care and was fully comfortable throughout their life. Now, there was one big reason for this. This is also the same group that you may have heard about that have donated their brains for Alzheimer's treatment. Each one of these ladies, when they pass away, their brain is analyzed to see if they've had changes for Alzheimer's or not. It's a study that's being done with Johns Hopkins, and it was very important for them, because of that study, to be sure that no dental issues had ever gotten into the study. So it's interesting to watch how that's progressing. And every step was taken basically to try to equip Villa Assumpta so that we can do things. We may not be the most perfect place, but we were able to, through various donations, get everything. So here's our lovely little nursing home here. And, you know, again, what do we see? We see lots of wheelchairs. These are not highly mobile people. And I get the great title here. They don't call me dental director. I'm just Dr. Martin. He's a dentist. And what we have here is, you'll notice this is a little bit of a different environment. We'll talk about the furry guy later. But the furry guy goes along with everything here. It is not the world's newest equipment, but being as we go by donation, we take what we get. Shine was a major contributor to this, and I cleaned out one of my old offices and put everything here. But we have everything here, from digital x-ray to intraoral cameras to everything. We can do everything in here in our office that we can do at any other dental office. And I dare say there's probably a few places out there we're better equipped than. And we loaded up everything. We've been able to get bits and pieces and find out, you know, what we needed for impressions, what we needed for sterilization. And we even went ahead so that we could go bedside. This is what is known as a mobile dental cart. It is complete with compressor, suction, 3 handpiece setups. I can go into any bed in the facility, put this alongside, and if I can't get the patient out of bed, I can still do a filling right there. There are, you know, we've got a microelectric motor on it, so we've got slow speeds, high speeds, the whole idea. Something like that, we were able to get from a site that was shutting down, that had been doing what we'll call sealant program in a public school system in Virginia. We got 3 of these donated. We rehabbed them, and usually that's a $10,000 job. We got them each for $500. So there are ways to get equipment for this stuff that, we found, we've searched through, we've seen what's out there. Really, when it comes down to it, sometimes you just have to get lucky. But that's what it boils down to. These are great units when you have to go into things. These are gooseneck lamps. These are actually from the hospital side. But the goosenecks like this are available to be able to bring a good halogen light right straight onto the patient. You can bend it into any place so that if you're trying to actually do dentistry, not only can you have your headlight from your usual sort of magnification, but you can have this when you've got two good lights in the mouth, bedside, you've got some real good things to go with. Furry Critter. Furry Critter was a request from the nuns. They started a program with a dog named Nui, and Nui was an Alzheimer's dog. And their question was, would it help to do Alzheimer's and dementia patients with a dog present? Because they had found in their research in the Alzheimer's program that most of the dementia patients calmed down when there was a dog in the room. There's something universal about it. Now, this is the most expensive dog I've ever owned. That is an $8,000 dog. He has been trained in dealing with being a therapy dog. Some of you know that because I went through training with this at the MSDA, if I come to a meeting and I have the dog that day, he comes with me. He has multiple, he had to train the office staff on how to deal with him. But that's 15 pounds of Pomeranian that can go up into a patient's lap, and it's really amazing. You put that in an Alzheimer's patient. I don't know, has anybody treated an Alzheimer's patient? Everybody ever see him get very disturbed while you try to treat him? Put that in their lap. They start petting the dog. They don't care what you're doing. So it makes a real advantage to it. I know somewhere out there, Jane's here, she met him when he was a puppy. I kind of did a de facto thing asking her when she was president of the board if it was okay to bring a dog in, but he's now a completely trained, got all his papers, and he still doesn't listen to me, so what can we say? All right. Now, when we really started treating patients, we had to start dealing with things that we never knew about before. It really does take a team when you move beyond just saying, I'm going to clean teeth. I generally do this as six-handed dentistry. I bring in two assistants because the one assistant, if you're in a wheelchair or something, is usually in a weird place, and they're not going to be able to move. You need somebody to supply things, and you need to be really quick and efficient. Matter of fact, probably in a 3-hour period, we'll do 6 patients. And that's a lot to do even in your regular office, but we get up and we get moving because they're not going to be able to sit very long for you, and you need to get the things done. And that's why I bring in this picture. This is my team. Now, what's unusual about my team is I have 2 guys. The reason why we found male dental assistants is no knock on any of the women assistants, but a big, healthy guy is sometimes a healthy thing to be able to move these people. You've got to learn not only how to do the dentistry, but you need to take some time to learn how to lift them, be able to manipulate them, because if you don't, somebody's going to get injured. Now, unlike Charlie, I live in the dark ages. The nuns don't really buy computers. And if you go into a lot of facilities, you'll see this. This is a chart. This is the chart from hell. It has everything about that patient in there. You have to really look and be responsible for what's there. That is a medical history like you have never seen before. So a lot of times I go ahead of time, I walk in, I read this stuff, I learn it before I go there. But that's not even my chart. I've got to take care of my charting for my own office because that stays on the facility. You've got to do double charting when you're doing this stuff. These are the people in the facility that really help you. In a full-time nursing facility, you have some RNs around. You need to make friends with them because they will tell you, You don't want to treat Sister Riley today. She's having a bad day. Or, okay, so-and-so's immobile. Tell us when they need to be down at the room because it's going to take us 30 minutes to get them there. They only have to move 2 floors. Now, this goes back to the other issue. Trained in transfer. You do not want to have anybody falling. You find out who's mobile, who you have to treat in the chair, who goes along. You get it healthy like my assistant here, Jorge. Jorge right now was a big loss to us because he decided after doing all this he wanted to go to dental hygiene school. So he started at CCBC. He told me yesterday when I was talking to him before I came down here that hygiene school made his head hurt. So we'll just give that to you guys. So, but here's a typical example of where we can get into a wheelchair position. If you've got the good support tabs, there are certain supports you can add to a wheelchair, like you can see behind her head. You get assisted into place. You can move chairs around. We can get in this room, dental lights, get my stuff in here. We're practicing pretty normal now, aren't we? You can do that if you get everything set up. And we can do full dentistry. There's nothing wrong with that type of situation. Now, as we say, we bring a laptop along. We have everything going in the soft end. We know, as well as our regular patients that are up there in blue, we know when we're at Villa, who our appointments are, where it's scheduled, what's going on. It takes planning. You need to know where everything is in the chart. You want to see everything. For your own office, if you're ever called in for malpractice on this, you need the same amount of charting that is yours as you do for the facility, because unless you have an agreement with the facility and you get called in a malpractice case, you may not be able to get that chart to defend yourself. So you back yourself up with the charts. And we do the full things. We get records. We put the whole thing in there. It's something to think about. It's a lesson that you really should think about. Like Charlie, I don't use the cassettes. I use a lot of bags. We have what are known as our boxes. We have our full sets of containers here. When we set up those schedules, everything goes in here. We know where it's labeled. We know who we want it to go for. I have one assistant that sets up the morning of, because if we're going in there at 2 o'clock, that assistant has loaded everything in. We don't have any questions. In this environment, treatment planning is essential. You have your treatment plan, you follow it, you do it. That way all the stuff's there, no headaches, and they get the treatment that they deserve. To that extent, we look at all this stuff and, there's other things to bring, as Charlie just said. You can't live without your magnification, your loops, but you need to be sure everything goes in. I mean, we even go as far as bringing sure that we got the little goodie bags for the toothbrush to go back to the patients here. Very important that they see everything. Charlie, I like your background. We think alike, don't we? Other thing you got to do for on site there, make sure for that site everybody has their licenses there so that they know if somebody asks, is everybody licensed? Yep, they are. And you also have to, many times with a facility, make sure you go through, just like Charlie said, it's just like going to getting into a medical staff of a hospital. You're going to have to prove your credentials, no matter what. And last but not least, if you're going to be at the facility and you're going to use a Nomad or anything else like that, be sure you've got the Department of Environment facility. You need to have it regulated for the nursing home you're in. Your office doesn't cover you. And as we found out down here, everybody, your staff that's there, got to have the badges and the records. Just because you do it in the office for that employee, it is not covered at this site. You have to have separate badges. Now, one of the golden things that we love to have around that's very important to us is the land of glass ionomers. For the dentists that are there, you're going to find out that this is a savior in very many places. We have found recently that it is hard as amalgam, and it's also rated to last almost as long as amalgam. If you're going to go bedside and you don't necessarily have a titurator or anything else there, this is a very good product to keep around And I've even used this in the anterior, and it's got enough quality that it's finishes close to a composite. So something to think about, something to look at if you're going to be in there, because if you don't have much to do, a lifesaver can be getting that glossotomer in there, getting that tooth filled, making the person comfortable. And as we said, you know, it's full dentistry. I mean, it's full on. You learn how to get your assistants in there. You learn how to treat. This is the case that we're doing in the chair. You know, there's nothing, once you get them in the chair, that's any more difficult than what you do in your own office. It's a great story about positioning, because if you try to put yourself into their situations without taking care of positioning it properly, you'll break your back at this very quickly. I mean, just like in your own office, you got to watch all the things that you would with your positioning, and also because they're that much more fragile and may move suddenly, it's very important to be having control over the position. Now, here's the in use with the not at Villa Sumpter. I didn't have a picture for that, but you ask how this guy does it. The furball does have an ability to just lay there with a patient that's a special needs patient, and because of the way he's trained, he'll do that. Now, you can't do this with a Labrador. So most of the dogs that are being looked at for dentistry, you're looking at anything that's under about 15 pounds, because it just doesn't work otherwise. And it is a commitment for everybody you work with, because, you know, you got to check, okay, do the patients have allergies? Do the staff have allergies? Do the staff like dogs? You know, what happens on the day that you go somewhere and he doesn't? Is this, you get a staff member that's going to take him home? Are you going to pay him more for that because that's a job that's more? There is a tremendous list before we go down that, and that's a whole nother lecture, but I'll just tell you, it is something you can look at if you're doing needs type thing. Standard things that we do while we're there. Luckily, I was trained by my dad insisted when I was about 16, I take lab tech courses at the community college. So being a lab tech, we get a lot of broken dentures. The thing about a denture is you just never know when a nurse's aide pulls it out, drops on the floor. It's nice to be able to get that done on site. You're going to see lots of things like that. By the same token, you'll see things like this. It's a lost bridge. We'll do the crown and bridge and replace it. It just was normal there. Old teeth fracture. That's a crown that we later worked on. But you know, the big thing is digital radiography is your friend. We use phosphorus plates because I sometimes have women that won't open very big in this whole thing. Phosphorus plate goes in there, hit it with the Nomad or hit it with the GE we have next to the chair, and I can get quality x-ray like this. Maybe somebody could pick on me for not getting the apexes exactly right, but when you can get something like this on a patient that's 90-some years old, you can diagnose everything that's there and do good dentistry. It's possible, and I will tell you the number one thing to use is use those phosphorus plates, because you can get that developed quickly and you can get it in and out of the mouth easily and not hurt anybody. All right. Somebody asked a question about how do you get paid? Well, this is pretty straightforward. I get paid through the grant as submitting traditional insurance. I'm getting the same rates as being in my office under this particular thing. Don't know how it's going to work when we take it out into the bigger world, but we've got a dead spot here. All right, so couple things to think about before we finish up on all this, because we're trying to get a little bit back on time. I won't take out the other part of the program here. Not only do you have to think about the payment, the other thing you got to think about is staffing. Everybody that you take on the site with you as an employee, there are a couple things you really have to think about as we wrap this up. One, are you insured for that site? If your malpractice doesn't know you're going there, you may not have coverage. You have to look at the insurance for all this. Second of all, how are the employees getting there? If it's part of their job description, they're driving their own car, are you covering that? What happens if they get into an accident? I drive all of my own employees in a vehicle that I've already talked to the insurance company about and said we do this with, because you want to cover that. You also have to find out, are you under the facility's liability? If you're not listed on their liability and something happens, it may all be with you. So it's a very interesting thing to look at, but be sure you carry the same coverages that you do in your office and that your employees are covered for the travel to get there. Otherwise, although you may be doing a good deed, you may not be covered. So as we go through all these good things, it's a great thing to do. For me, it's been a tremendous staff builder. You get a tremendous amount of goodwill with it. And I have to say, out of the way we've developed this particular system, you know, one of the things that you get is when you go on site, there's a code that is in the back of the chart. It's in the 9000 series, which is a code for being on an off-site facility. That means you can, if you have the billing facility, you're billing not only for being the procedures that you're doing, but you're billing for that other fee. Now, it's not a big fee, but you know, $65 here, $65 there for every patient you see. I will say that if I see 6 patients in the afternoon, that's another $300 or $400. That pays for you being off-site. So in the end, it's an economic wash for your practice. And in these days where some people are struggling to find things to do, if you can get it set up in the right funding in one of these facilities, it can, for a young dentist or someone who's looking there to grow their practice, be a nice way to get out in the community. And by the same token, what's going to happen? Well, those nuns talk to people. They had lots of students. They come in to visit. They say, oh, Dr. Martin was nice enough to take care of this tooth. It's good for your practice. So this isn't only good for the community, it can be very good for you. And in the end, everybody kind of wins. So I look at this as a win-win philosophy here. So we're back on our schedule here, so we're going to get our last speaker for the morning from the Maryland Healthcare Commission. And we will go ahead and then finish up with all the questions and answers from there. So I'm looking for, is she here? Oh, there she is.
Thank you. Good morning. My name is Angela Evad. I'm with the Maryland Healthcare Commission. I'm going to be presenting briefly about the Maryland Healthcare Commission Health Information Technology Initiatives.
Or you can use that if you need
Either
to.
way.
Okay.
So I'll first start off by talking about who the commission is. And many of you might not have heard of the Maryland Healthcare Commission. And I'll also overview some of our health information technology, our HIT initiatives. And finally, I'd like to engage with the audience a little bit and talk about opportunities that dentists can take advantage of and involve themselves in our current initiatives. So to start out with, the Maryland Healthcare Commission is an independent regulatory agency whose mission is to plan for system needs, promote information decisions, increase accountability, and improve access. We're an independent regulatory body under the Department of Health and Mental Hygiene, and I work within the Center for Health Information Technology. The Commission's vision for Maryland is to ensure that informed consumers have access to affordable and appropriate health care. So our role is in advancing health information technology is threefold. Basically, we are establishing a collaborative, multi-stakeholder, consumer-centric statewide health information exchange, or HIE, for the secure exchange of information between disparate health systems. And I'll briefly talk about the HIE in Maryland. We're also responsible for developing those robust policies to ensure that information is exchanged privately and securely among the healthcare providers. And we also want to substantially increase the adoption and meaningful use of electronic health records across the state of Maryland. So why are we doing this? What are the benefits of health information technology adoption? Basically, the key benefits are minimizing duplicate or inappropriate testing. To have that information at your fingertips, to understand your patient a little bit more fully than the current record within your practice, so that you can make informed decisions. Avoiding adverse drug events, knowing what prescriptions your patients are on to make a decision about keeping on that medication or selecting a new medication. And another key piece is to lower administrative costs. We believe that health information technology can be a tool that could benefit the triple aim of healthcare reform to increase healthcare among patients, increase patient satisfaction, public health, and decrease costs. So today I'm going to talk about 3 components of health information technology: electronic health records, telemedicine, and health information exchange. To first start out with electronic health records. For a show of hands, how many folks have adopted either an electronic dental record or electronic health records that's beyond their practice management system that's currently practicing? Show of hands. Who's adopted an electronic health record? Oh, just a few. Sure. So the question is that to explain a little bit of what that means beyond your practice management system. So a lot of practices have adopted technology to work on scheduling, so getting the information to their patients in terms of their insurance, when they're going to come to the office. But what I'm talking about when I'm talking about electronic dental record, at least defined by ADA here on the slide, is having information electronically within a computer system that has diagnostic information about your patients, the charts with an electronic format, treatment plans with an electronic format, progress notes, digital images. On the electronic health record side, it's a little bit different. It includes a more longitudinal history of the patient, clinical notes, medication list, allergy list. And some EHR systems also have electronic prescribing capabilities within them, so you can e-prescribe out to the pharmacy. So knowing that, maybe I can ask the question again. So folks in the room who have adopted at least an EDR or electronic health record within their practice. Much better. I was getting a little worried there. So what are some of the potential benefits of adopting electronic health records? Similar to the adoption of health information technology, we're looking at improving care coordination and access to those records, reducing errors and increasing access to clinical decision support. So some electronic health records have built-in clinical decision support that have intelligence in the background that allows you to be presented with information about a particular treatment that you might be working with on that patient based off of that patient's history and the records within that system. We're also looking to improve quality of care with electronic health records, from preventing unnecessary procedures, and again, increasing patient satisfaction. So what is adoption in EHRs for dentists? At least what we know from the ADA from 2012, and we're hoping to get more recent data, is that it has increased over the past several years. In 2005, it was only about 1.8% of dentists that are completely paperless within their practice, and that's increased to 15% in 2012. So in terms of comparing that on the physician side, we have more recent data, at least on physicians. Office-based physicians in the state of Maryland are about 49%, and nationally about 45%. So what are dentists capturing in their records? Mostly patient appointment information, but beyond the practice management system, we're looking at treatment plans and images within their systems. So I'm going to take a few moments and talk a little bit about where dentists are in terms of the EHR incentive programs. So dentists qualify for Medicaid EHR incentive programs. And how many people have heard of the meaningful use incentive programs? Great. So in terms of dentists, we know that there are about 45,000 registered dentists in the state of Maryland. Of those, at least in 2012 data from Meaning for Use, is that 174 have registered to take advantage of those incentives. Now, I heard briefly in a presentation before this, there are about 1,000 or so Medicaid dentists. So that's sort of what we're looking at in terms of the population that could potentially take advantage of the incentives. Where the 174, only about 61 have received payment now. And the payments are, in the first year, about $21,000, and every 5 years after that, consecutive years, about $85,000 for Medicaid patients, providers or dentists. They can take advantage of it. So we're seeing a low uptake among dentists and taking advantage of the meaningful use incentives. So why is that? A lot of the challenges that we've heard, and I've sort of put a Venn diagram that looks at the challenges, because these are all interrelated. Time being one. Migrating from paper records is many challenges that I hear from dentists around why should I adopt an electronic health record if I'll experience a lull in my practice and revenue over the time that I'm migrating from paper records. Workflow. It has to be incorporated within the practice's workflow. That sort of takes time to transition to that, and also time is money. So also the business case. Some dentists don't really understand what is the return on my investment. If I'm going to pony up a lot of money for the electronic health record, I want to ensure that it's going to be a good return on my investment. Operations of an electronic health record as well. Many electronic health records might not have capabilities to be interoperable, and I'll talk a little bit about what that means. Basically, being able to talk with other systems within your practice. You might have a practice management system, other electronic health systems, and putting another system in your practice that doesn't talk to those systems is really not a benefit of the practice. So that is another challenge for some dentists. And then there are privacy and security concerns. Obviously, dentists don't want a breach to happen within their practice. Electronic health information can be more easily accessed in some regard, but there are protections through EHR adoption. So I put up a slide here. Maybe I'll read it for the folks in the back. I can't decide what smartphone to buy. Which one will solve all my problems and make my life perfect? Now, we know that electronic health records can't really solve all our problems and make our practices perfect. But what I wanted to do is speak with you and hear from you in terms of, what can the Maryland Healthcare Commission do to support dentists in terms of EHR adoption? Now, we've done a lot in other areas, and typically our tools box is we're able to sort of collaborate again, among stakeholders by bringing people at the table to really solve some problems collaboratively. We work with legislators to implement laws that can help some of these challenges, and we also write regulations to help with these challenges. So I wanted to hear from you guys, and I don't know if I can't move actually away from my podium, but maybe if you show of hands and talk about what could the Maryland Healthcare Commission do, what would you like to see in your practice that could help expand EHR adoption? I know you guys haven't talked too much during the presentation, but I know you aren't a quiet bunch because I've been here 3 times already. So I'd like to hear a little bit from you.
I've recently wait for the mic. Like I said before, guys, we're trying to get everything on the video, so if you wait on the mic, it's going to be important to this.
I've been getting the Wall Street Journal for free, and so I've been reading the Washington Post and the Wall Street Journal, which takes a huge amount of time. Anyway, I think it was the Wall Street Journal that had a letter to the editor from a physician who was bemoaning his having to electronically keep records, and he was saying that that this was directly manifesting in his practice by spending less time with his patients and, quite frankly, less time with his family, because he was having to make up more and more time at the end of the day, and that that reflected in less time with his 2 kids and his wife. So, you know, I guess I'm not electronically, I don't have electronic records, but, you know, when you read something like that, you know, it does, I do volunteer at the Spanish Catholic Center. They have electronic records, and I move from chair to chair, and the assistants, you know, essentially do my work for me, so I can treat patients. So it takes away from the ability to treat patients.
I've definitely heard, I've actually read the article, and there is some debate in terms of, you know, what is the efficiency of adopting electronic health records. Is it really a return on my investment? Am I able to treat more patients? Am I able to see patients and treat them in a better way with an electronic health record? And there definitely work to be done with vendors, with electronic health record vendors, to make the systems more user-friendly, more easy to use within the practice workflow. Because electronic health records are new, at least in terms of, you think of technology, there are a lot out there. There are a lot to select from, and most practices want to be able to customize that system in order to not have to spend the hours at the end of the day using the system. And some technology vendors are more sort of flexible with customizing that system to the practices. Others aren't as flexible, and I think doing particular homework around what that system can do and can't do for you, I think is very important when we go about adopting. So another opportunity is, you know, is it about educating providers around what technology is out there, what services are available, what are providing a forum for dentists to talk about what their experiences have been in adopting. So is it good for you to talk to colleagues that have adopted an EHR to understand what are the benefits, what are the challenges, and how you can learn from that? We have another question?
Yeah. Hi, Angela. Great presentation. I have talked to some of our physician colleagues, and I do think that the front end of EMR conversion, they do bemoan it. I mean, it's not fun. It's time consuming. I do think there is a, kind of like a lot of us already have electronic charts in our office, it is efficient and time saving after you convert. But my question to you is, you talked about stakeholders. If you look at dentistry, you have management software, Dentrex, EagleSoft, SoftDent. I don't know what the market shares are, but you probably do.
Yeah, that's
Is there any conversation with them to try to bridge so they can talk? Has that already been done, or how are they responding to that conversation?
Sure. I've actually reached out to the 3 big dental providers, electronic health record dental providers in the state of Maryland, to understand sort of what their idea or concepts were around at least getting their technology certified. So when I say certified, EHR is if it's certified, then you're able to use it in a certain manner so that you can take advantage of the incentives. But I think that's certainly not the end game in terms of EHR adoption. It's not just the incentives. It's working with the dentist community in order to figure out what technologies that they need. But certainly we can explore more conversations with those EHR vendors to understand what their models are, what we're hearing from dentists, to communicate to the vendors. And we've done that before in the long-term care community when we were talking to long-term care providers about what they might need in their practices, and not the big chains, it's usually the smaller guys. And we've worked with the long-term care EHR vendors, and we can do those types of stakeholder building again with the dental community. But what we want to know is, you know, what does that look like, and how will that be benefit to you guys?
Okay, you may have already mentioned this and I missed it, but will Medicaid providers be required to adopt this?
Adopt an electronic health record? Mm-hmm. So I get this question a lot, and not just from dentists, but in terms of quote-unquote required, there is no mandate that says that a provider needs to adopt an electronic health record. However, if you are qualified under the Medicaid program, EHR incentive program, and you don't adopt an electronic health record and meet meaningful use, then you will see a decrease in your reimbursement. But there isn't something tied to licensure or we've heard from payers that you have to or requiring to adopt an electronic health record.
Okay, we're going to take one more on this subject. I'd like the other speakers to head up front, and we'll open our general thing up after this question. So Charlie and Harry, if you can head up there, and I'll come on up, and hopefully we can get somebody to run the mic around. But go ahead.
My question has to do with liability associated with disclosure of information through an electronic system. Once these health records are electronically disseminated, what sort of security are you taking to make sure that this information is not passed on to other organizations, insurance companies, and possibly used as a marketing tool to God knows who?
Right. I think that's a good question. So, in terms of the Maryland Healthcare Commission, we're not regulating electronic health records in the state of Maryland at this point. A lot of what we're doing is educating providers who are choosing an electronic health record system to understand what agreements they're signing with an electronic health record system. And typically right now, you'll be purchasing an electronic health record system that's going to be remote hosted. So the data isn't sort of on a server within your practice, but it's on a server within that agency, could be within any state. So you want to be concerned about those particular things in terms of how they're using that data on their server. Are they making it available to researchers or for secondary use? So educating yourself about those details from the vendor is important, and looking strictly at those use agreements that you'll be signing it is important. But we're not at this time sort of regulating an EHR system where they have a server to ensure that they're following best practices.
This question is to Dr. Doring or Dr. Mark. Are you aware of any CE courses for dental treatment nursing homes that are available?
Excellent question. Excellent question. 2 mics. The Maryland State Dental Association, along with the dental school, and Eric's been very, very helpful in this. We just put together a grant proposal that is going, what's the name of that group, Eric? It's Dental Manufacturers. Dental Trade Alliance. We put together a grant proposal we should hear by November, and the funding on this grant proposal, should Maryland State Dental Association Foundation get the grant, would be to educate providers, dentists and hygienists, to work as teams to go into long-term care facilities. So I would say stay tuned to your MSDA, your Dental Hygiene Association newsletters, and hopefully we'll have some positive news. And I want to thank Eric for many long nights working on that grant application.
This is fun. Allow me to add one of the other things is a lot of your community colleges have allied health programs where things like figuring out how to move somebody, how to deal with the nursing facility and things like that have good programs for your staff. They may not be directly dental, but a lot of that stuff in the community colleges will help you be able to better treat these people and get your staff so they know what's going on and are trained for those environments. Eric, you get.
You mentioned a pond. What's the name of the dog?
For those of you that know him, that is Rusty.
Rusty. All right.
He's probably the only dog that visits the MSDA regularly.
Well, I had Piglet and Snooze, two cats, and I had one patient who was allergic to cats, and of course the cat went right to him, you know, and he fell in love. I've got pictures of the guy with the cat sitting on his lap, and he would wash his hands after the appointment, elderly patient. Yeah, cats, you know, a lap cat is a wonderful animal they have in the office. Now, I don't know what the Board of Dental Examiners had to say about that, but it does work well.
If you allow me to go to regulations on all this, the FDA has basically only legally put 2 animals into the formal version of therapy animals. The reason why I have a dog is because dogs and horses are the only true recognized things right now. Many people are trying to claim everything from iguanas to their pet fish they need to take with them into facilities. The actual regulations have been written for dogs and they've been written for horses. They do mandate a certificate from a training facility. You can't just write your own thing. I spent $4,000 with a trainer in Baltimore by the name of Iris Rosenberg. Bless her heart, she's passed away now. But, you know, if you're going to do it, just don't bring in the family dog and say, here, because you have no idea how they're trained to deal with it. It's, if you really want to take it on, there are groups and there are facilities that will train them and do it properly. But I don't recommend you start bringing the family dog to work. Eric, you got somebody over there?
Yes, I'd like to know, are we engaging in conversation the nursing home directors and the regulatory people for nursing homes to let them know that we're doing this and let us in your doors, please?
I'll try to answer that. It's my understanding that in licensure for long-term care facilities, mainly nursing homes, there must be a dentist name on staff. Now, whether that dentist routinely goes in or it's someone the nursing home facility can call when there's a question, there's different grades of that. Our emphasis here is to, and when I talk to the medical directors in November, is to make sure that there truly is a dentist on staff at each facility that residents can have care from, whether it's a mobile van that pulls up to the front of the facilities and patients are wheeled out there, or the dentist like myself that comes in and does exams that way with the dental hygienist. We're definitely going to have that dialogue with them coming up in November.
It's my understanding, because I just got done doing Villa Sumpta's review. They have now put that as a priority item on the review for things, so that nowadays, a lot of times there's places like facilities that have had names on those places for years where nobody's ever walked in or looked in a mouth, but now it's actually something they're checking for, and believe me, I had to be there while it was being done. So it's actively something that they're regulating, and it's a big reason why we're starting to train now, to make sure people take care of these opportunities and take care of these people.
It's a great question, and I think it's not going to happen on its own. I think that, you know, the work of Charlie and Bill and many others, when you go into your nursing home facilities, you need to engage that nursing home director, and you need to begin speaking the talk, you know, talking the talk about how this needs to be not just in one center but all of them, because there are dentists on staff supposedly on many of these centers, but it's a federal regulation. So excuse the pun, it doesn't have any teeth to it. It doesn't happen all the time, and so I think that's why it's so important the work is being done to engage the nursing home director and talk about what's going on in your neighboring nursing home center, and that this needs to be the state of the art for your center as well. It's a very, very important question.
Yeah, I had a question actually for the audience, and the question came up about courses in long-term care. I guess I'm just curious to know, as a leader at MSDA, how much of the audience would be interested in further courses in long-term care and nursing home care? I'd like to see a show of hands so to direct us, you know, to try to provide that. Thank you.
All right, any other questions out there? Way over there. Greg Allen from the wonderful Eastern Shore, Mission of Mercy, and all sorts of good things there.
April 17th and 18th.
I knew that was coming. I knew that was coming.
Mr. question, probably more for Harry Goodman. Is there any current grants that are written or anything to try to? I had the same kind of scenario these guys did. I served at Genesis for a while here on the Eastern Shore. Through a patient, I ended up getting integrated over there, became active on staff. And something that I've noticed is that it seems like we need to educate the physicians, the nurses, the people that are taking care of these folks on a daily basis to get them to identify this stuff. And something as simple as oral hygiene regimens, as well as going back and identifying early issues. Because we're not always there. It seems like we were always called in for a problem, for an issue usually. Is there anything that's in the works at the Maryland State level to try to an educational program for the people that actually run these facilities, either the directors themselves or the RNs who are really the daily caregivers?
I think I mentioned in my presentation, we do an annual in-service, and actually it's probably more 2 times a year I go in and talk to nursing home staff. And it's a very important point. When we did our long-term care initiative back this past winter, we also, besides residents, we also screened nursing staff, and quite a few of the nurses' assistants participated. And I hate to say this, but the worst dentition that whole day was a nursing assistant. So again, if their home care is poor, they don't have the dental IQ, they're not going to do excellent home care for the patient. So what we do, and I'm working with Laurie, the dental hygienist, is do a more in-service, more how to do exams, how to do screenings, when to know when to call me in for a consult. And I would say some of the staff really gets it, especially the speech pathologist. She calls me in weekly on cases. But some of the other nursing staff, they are required for licensure, just like we are, a certain number of hours of CE, and they do get recorded for being present on taking those courses. And we try to make it exciting and involve them so that they get the message and learn how to provide better home care. So hopefully it's a work in progress.
Good question again, and we've been really advocating for a lot of training in other areas of our medical colleagues, and I think this is one area we have not yet done, and I think it's a great area to begin to talk. We do have to train everybody, the staff, nursing, the physicians, what have you, and I would definitely be interested if we can get partners together, through the Dental Association, maybe the coalition, us, to sponsor such a program and hopefully be able to attract them. Now we have to figure out how to attract the physicians to a training program. They're a tough group to do, and maybe we have to do it on site or do something, figure it out, but I think that's absolutely needed, and that's certainly what we're talking about now, a lot of medical dental collaboration, and as we move forward with the older adults, it has to happen. So I think it'd be something we could talk about.
All right, any other questions there? All right. Good.
Do any of the hygienists in the room, do any of you know, I was talking to a hygienist recently at a meeting in Frederick, and she's worked in the Maryland, University of Maryland Dental School. They developed a training program on DVD. Do anybody know, have heard of this? It's about how to develop long-term care programs.
Yes, I saw it. I saw her presentation, but I don't know if it's...
Is it applicable to what we're talking about?
Yes, yes.
Okay.
It's great. It talks about all of that.
What's her, do you know her name? I know the program's not released yet, but it's...
I'll let you know. I'll think about it.
Okay.
So I am Diane Romaine. I'm president of the Maryland State Dental Association Foundation and past president of the Maryland State Dental Association. And this afternoon, we're here to pose the question, are Mission of Mercy projects and regional dental safety net projects really making a difference in lowering emergency department dental visits across the state of Maryland? And I'm here to tell you the answer is an emphatic yes, and we have the data to prove it. Of 52 hospitals in the state of Maryland, when we look at our stats as of 2013, only 8 of those 52 had lowering emergency department dental visits and charges. One of those 8 was actually Union Memorial Hospital, adjacent to the University of Maryland's Perryville Clinic, ongoing adult safety net clinic. 6 of the other 8, do you know where they were? They were all in the vicinity of Maryland State Dental Association Mission of Mercy projects, which I'm really excited to say. Just 2 weekends ago, we had, I think, what was our most successful project ever at the Xfinity Center at the University of Maryland. This was a tremendous collaborative effort with a lot of help from the University of Maryland Dental School, the University of Maryland School of Public Health, and even Catholic Charities, who we were happy to welcome to the team. So as I was working on somebody, I looked up and in walks Cardinal Donald Wuerl from the Archdiocese of Washington. So it was really a blessing. But I'll tell you, as fun as it was to meet Cardinal Wuerl, who kind of had the bigger impact on me at this clinic, was a patient who I got to treat. So I got up and I walked over to shake this gentleman's hand, and you could tell he was really trying to be a little dressed up, long white hair and a beard. And as I reached out to shake his hand, he said to me, "Well, Doc, I know these clinics make you and your colleagues feel good, but this is one heck of a way to deliver dental care to a United States Vietnam veteran who's been to the emergency department 3 times for this tooth." So I was a little overwhelmed, but I shook his hand and I said, "Sir, I know, and I and my colleagues are really trying to work on it." And I really believe that we are. Incidentally, it was kind of funny. I had to take out tooth number 14. I was on the last battery light of my life, thinking of my friend Trish Kruger a few rows over. And just as soon as I got the root out, Catholic Charities had a choir there singing, so the choir started singing. I was like, "Thank you, God, this is great." And I said to the patient, like, "Isn't this music great?" And he said, "Oh, I think the music's more like the sinking of the Titanic." You know? But it just goes to show you, some people view the glass half empty, some view the glass half full. And as much as you can have people who really struggle and who have a lot of issues in their life, and those are a lot of the patients we're seeing, there are also some tremendously grateful, amazing people that we care for at Mission of Mercy. And I'm going to show you some of those people here.
My name is Michelle Boyle. Mission of Mercy has made a huge impact in our lives.
And I'm Fred Randall, and I volunteer and was a patient.
The very first Western Maryland Mission of Mercy, I was recruited by my employer, Allegheny County Social Services, to come as a volunteer. The way our lives had been for years, we never had an employer that offered us dental insurance. Fred hadn't been to see a dentist since he was a small child, and he had very bad teeth issues. So I heard about it through work, and I insisted that he go out as a patient. The very first time that day he came home, and the work that they did for him was so magnificent. He came through the door, he smiled and showed teeth for the first time in 14 years, and I cried. I vowed from that day forward that the work that was done could never be repaid, just to see that smile on his face. So I have now volunteered at 6 different Mission of Mercies across the state of Maryland, and as long as I can continue to, I will be at every single one that I'm able to attend. I can never pay it back. All I can do is try to pay it forward.
It was fall time, it was freezing cold, and it was at the Allegheny County Fairgrounds. I walked about 1.5 miles. I sat there for over 16 hours with nothing to eat. Everybody was cranky, and it was hard. But by the
I've used vacation time to go and volunteer. The amount of people that it impacts, the sheer numbers are amazing. And when you see people leave with smiles on their face, even though they're in pain and they have bloody gauze hanging out of their mouth, they're so thankful. They feel so blessed that they were given the opportunity to have this service that they can't afford. They can't even get insurance to cover it. Or even if they do have insurance, there's still money that they still have to pay out because the insurance doesn't cover it. It's a real shame that for a long time Medicaid did not cover dental services for adults. There are a lot of people in our area and across the state alone that are on Medicaid, and I realize with the Affordable Care Act, things have changed a little bit, but we just recently went to dental visits to get our teeth cleaned and to get an exam, and some of the work that needed done is going to cost us several $100s that we just don't have. We have 2 children, we have bills to pay, a mortgage, vehicle, all of those things, and there just isn't the money for something like teeth. But we realize how important it is. And unfortunately that happens to a lot of people. So the mission impacts so many people in such a positive manner, and I can't count how many smiling faces I've seen at the end of each mission.
Okay. So I apologize for our scatty video, but I think you guys got the message overall. Since 2010, when we started our first Mom Project in Western Maryland, we've now done 8 projects, cresting, I think now over $8 million worth of free dental services across the state of Maryland. But whenever this concept was first thought of, there were a lot of cautious kind of people out there. Even talking to Dr. Goodman, you know, we were worried that we really wanted to do it right. We wanted to use the highest of infection control standards. And I think we've done that, and I'm really proud of the programs that we've done. And I think some of the initial people who are most cautious are some of our greatest champions now. So I want to thank them for that. So these programs are really becoming recognized across the state, even through hospitals. So last year, I had a phone call through the MSDA saying, hey, Diane, they want you to go to the Maryland Hospital Association annual meeting to pick up a grant for MSDA Moms Projects. So they want to give us money? This is great. You know, we didn't even ask for it. So I went to the Maryland Hospital Association meeting, and there I had to sit through about an hour before it was time to receive this grant. And as I sat there, I started hearing a lot of acronyms that I wasn't familiar with. What is the HSCRC, the Maryland Health Services Cost Review Commission? What is the Medicaid waiver that Maryland has? And it kind of started putting some pieces together and creating some comm lines between MSDA and the world of hospitals. So Tracy Laval, who's Vice President of Finance at the Maryland Hospital Association, coordinated a meeting between us and Oscar Ibarra, who's the head of the Maryland Health Services Cost Review Commission. And why this group is so unique, the HSCRC, for those of you who might be unfamiliar with the acronym, is because they are one of the only groups in a state such as Maryland that actually determines and fixes the rates for all hospitals in Maryland. They also, very, very unique to Maryland, set the same rates for all payers. So if you went into the emergency department at Johns Hopkins Hospital with a dental trauma, if you were a private pay patient, if you were a Medicaid patient, if you're a Medicare patient, you pay the same rate. So as a commercial insurer in the state of Maryland, it's not a confusing situation of trying to negotiate what you're going to be paid. But what it also does for us is it gives us an amazing ability to really understand the statistics of exactly the scene of what's going on with emergency department visits. Data is collected from hospitals via what we called ICD-9 codes. As dentists, again, I was not familiar with this. A patient comes into the ED, the doc writes some chart notes as to what their diagnosis is, and a coder codes what is the ICD-9 code that this is going to move forward as. Lastly, what the HSCRC does is it has agreed to one of the only states in the country, Maryland, to have a waiver from Medicaid, which limits and controls our hospital costs to a growth of just 3.5% per year. So as much as we had a little bit of a confusing rollout with the Affordable Care Act, these other things that I'm talking to you about that are very unique to Maryland really are creating some intense innovation because they are controlling costs. They're also creating equity and rewarding value, not volume. In other words, a hospital has no incentive to open its doors to emergency room dental patients because they're making more money. That's totally not true. It's actually a hurt to them more than it is a help. So in no way are hospitals saying, yeah, come on in, come on in. That's not true. So this is what an ICD-9 dental code is. If you look over to the left of the slide, the coder at the hospital is, from reading the physician's notes, going to determine, is this a disease of the hard tissue, a 521, 521.9? Is it a disease of the pulp? You know, whenever I first saw these, I was saying to myself, my gosh, it's hard for me to tell as an experienced dentist of 20 years with an x-ray in ideal conditions what my patient might have of this left column of most commonly used dental codes. Imagine an emergency department physician with no periapical x-ray, no real significant dental training, trying to make this diagnosis. So what ends up happening is over 60% of emergency room dental visits in the state of Maryland and across the country are coded as other disease of the oral cavity. So what happened is MSDA reached out to the Health Services Cost Review Commission to gather the following information. We asked them for inpatient and outpatient hospital data by county, by hospital, by payer, and by age from the fiscal year 2009 to 2013. And I'm happy to say, as of last weekend, we actually just received the 2014 data, which I can verbally give you guys some updates on, but they aren't even in our graphs yet. So under the direction of George Shepley, after we went to that meeting with the Maryland Hospital Association, got our grant, created relationships with the HSCRC, we started meeting as the MSDA ED referral work group. I think that first meeting was last November, again in March, and we just met last weekend. So gathered here around the table, this meeting took place at the President's Boardroom of the University of Maryland, Baltimore. You see over to the right in the corner, Oscar Ibarra and Claudine Williams from the HSCRC. Straight ahead, the CFO of Johns Hopkins Hospital, Ed Baranek. Manny was in the audience there too. Dr. Emmanuel Finn, the dental officer who's waving his hand back here from Anne Arundel County, was there at the table. And it was a unique kind of relationship because Manny sat right next to Bob Riley, who's a finance officer at Anne Arundel Health Systems. So this group's really trying to bring people together and get people to talk to each other to really work on this problem comprehensively. Again, representatives from the ADA and representatives from our friends at MDAC2. You could see some of the logos of who was involved. Dr. Goodman's right under the screen in the background there. Now, whenever this group met together, we had basically three goals. The first one was to understand and write down the successful actions of hospitals that actually had lowering emergency department statistics. Secondly, to offer encouragement and assist areas across the state of Maryland that were reaching for ongoing projects but really just needed some help and guidance. And thirdly, to really look long-term, as Dr. Goodman was saying, at putting our efforts behind an adult Medicaid dental program in the state of Maryland. This was really a blessed program too, because as much as we had the Cardinals show up at the Mission of Mercy after this meeting, the Blue Angels flew over because it was the Star-Spangled Banner weekend. So that was pretty cool. Okay. So anytime you're trying to look at a situation that's overwhelming, I always say you have to get knowledge and you have to take responsibility. So as we look at these statistics, which are to follow, that's really what we're trying to do. So here they are. Maryland Hospital Dental Outpatient ED Data Summary. When you look at the graphs on the left side, and these graphs are current to 2013, these graphs were prepared by Daphne Ultima Johnson, our state dental epidemiologist. You could see, as Dr. Goodman alluded to earlier, the numbers in the columns of 0 to 10 and 10 to 20 are slightly decreasing. In other words, children with Maryland Healthy Smiles, they do have lowering emergency department visits. I think a lot of times, as I'm understanding, most of these visits deal with trauma. So we're always going to have a certain amount of emergency room dental visits dealing with children just because of what they're about. But what's more alarming is look what happens at the age of 21 whenever our Medicaid Maryland Healthy Smiles program recipients don't have Maryland Healthy Smiles anymore. 21 to 30 is the biggest spike range of age, and it's really the population that's most affected by not having dental insurance in the state of Maryland. The Medicaid dental visits from 2009 went from 15,000 to over 27,000 for Medicaid in 2014. That's not even on the graph yet. The total charges went from $4 million to $11 million. And whenever I say charges, all I'm talking about here are those ICD-9 codes that I listed in that slide previously. I'm not talking about physicians' fees. I'm not talking about other associated fees that go on with just walking into the emergency department visit. If I divide our Medicaid by the numbers, it ends up being about $300 a visit, but we know the cost is really more whenever you add those other things. This slide, Maryland Hospital ED Outpatient Data Summary by Payer. In other words, who's footing the bill for this service? And again, when you look at Medicaid, you could see those numbers climbing over time. The total ICD-9 outpatient data code charges for all payers in 2009 were $13.8 million. 2014, again, it's not even on the graph yet, they totaled over $21 million. So this is an increasing problem. And again, all we're looking at are the dental charges. This isn't counting emergency room physician charges or other associated charges entering the emergency department. On this slide, as I told you guys, we also asked for not only outpatient data, but inpatient data. The inpatient data was really broad, and it's something that as a work group, we really wanted to study further, because these inpatient numbers don't reflect the top 2 reasons that people would walk into the emergency department and happen to get admitted. They could include any one of 30 reasons. So these numbers are inflated, but I do believe this is an area the group wants to study further. And talking to Dr. Mark Reynolds at the University of Maryland, looking at future study projects as to what's the association with adults to dental needs and inpatient hospital visits. But here we can see our top 5 counties where we have issues. And as the foundation president, I think we want to guide our MOM projects and our safety net projects to target these 5 counties. Of course, just last week, we were in Prince George's County in College Park. Baltimore City, we have a Mission of Mercy project by our friends at the University of Maryland Dental School that's happening next summer. Where I would see a great need is helping to assist our friends in Anne Arundel County to maybe do a Mission of Mercy project or really help and encourage their safety net. So this is kind of a guide as to where we could focus our efforts. So have any of you dentists out there ever sent somebody to the emergency department? Okay, I have. And a recent RAND study says that most patients who go to an emergency department go because they are told to go by their doctor or dentist. Have you called your doc recently and got the answering machine and said, if this is an emergency, go to the emergency department? So last June, on the night of my daughter's high school graduation, I had a patient of record who had called the office about 4:45. Her tooth was killing her, and she said, please, can I just come in and see you? And I said, sure, come on in. So sure enough, she had an abscess number 3. She wasn't swollen. I got her numb. I put her on an antibiotic. I even did prescribe her narcotic pain medication because I knew this person. And I said, tomorrow morning, I will see you at 7:30 and we're going to start this root canal. But I'm sorry, I have 20 people coming to my house for dinner in half an hour, so I can't do your root canal now. So the next morning, I met her at 7:30 and she looked really sleepy. And this is a professional woman in Cumberland. And I said, well, what happened? I mean, did you have a rough night? And she said, oh my gosh, it was so awful. I didn't want to bother you. I went to the emergency room. So I was thinking, oh my gosh, there go our statistics. But this happens so often, and I think as members of the healthcare community and the dental community, we really need to look at our own ability to be available to our patients with dental emergencies. Because a recent study by the ADA Health Policy Institute actually said that 2/3 of dental emergencies at emergency departments happen after business hours. Also, about 2/3 are classified as not really urgent, semi-urgent, or non-urgent at all. And whenever the ADA Health Policy Institute looked at the cost impact of that, they estimated that $1.7 billion across the country, who knows what it is here in Maryland, really would have the ability to be diverted into dental offices and into Medicaid to better serve those people's dental needs. So our work group came together, and this is what we came up with as far as our successful actions of how the healthcare community could take steps to reduce emergency department visits. And the first thing that we saw is training emergency room docs is hugely important. Again, as dentists, it's sometimes hard for us to make a diagnosis, let alone an untrained emergency doc. I'm excited to hear Dr. Berman's lecture, because one other thing that we've gotten to hear from ER docs is they are really unsure what to do with dental trauma and some of those things that they need to kind of triage and settle and then send off to us as dentists. The second important step, which really diverts a lot of people from emergency departments, is having a policy of no narcotic prescribing for dental emergencies. The third is having a referral sheet that is handed out at the emergency department to a patient to know what dental safety net is available to them. And the fourth is really having all of us work together to establish sustainable and systemic programs for adult care. This is an example of the pain management guideline that's given out to patients that come through Western Maryland Health Systems. You know, now more people die in America actually from overdose of narcotics than car accidents, than auto accidents. That just crossed over last year. So it's a huge problem. It's a huge problem in my community. Now the health officer in the community has started a program training family members with how to deliver naloxone, you know, if they see that their relative is having some type of overdose. So it's something that's really important in communities, and this is given out to people as soon as they come in. This is an example of the emergency dental referral form that's given out that talks about resources and different income vetted programs available where I live in Allegheny County. Now, Allegheny County and Western Maryland Health Systems, I practice in Frostburg, Maryland, is a little unique. And as much as we're out in the boondocks of Appalachia, we have been early adopters of this Medicaid waiver. So at Western Maryland Health Systems, we've actually had 3 years into having cost controls put on the total global budget of the hospital. And though it was a struggle at first, now we're really starting to hit our stride and seeing a tremendous amount of care being delivered prior to emergency rooms at Western Maryland Health Systems. And this is really starting to cascade across the state as more hospitals are limited in their budgets and they have to come up with creative solutions to help people before they hit the emergency department. So in Western Maryland, I'm really proud to say since 2010, we've had a decrease of 25% in dental emergency department visits, just 12% last year. And yes, Mission of Mercy programs help to grease the wheel with that, but the real magic happens whenever ongoing safety net dental solutions start to come into the scene. And I'm happy now to introduce Dr. Rick Rogers, our MSDA president-elect, who has started from scratch one of those such safety net programs in Frederick and is going to tell you about some of the emerging wins that we're now seeing.
Thank you, Diane. We're going to talk today a little bit about starting a program. Being a upcoming president, I think Diane is past president. We have George here. Everybody knows that sometimes the state presidents are middlemen or middlewomen between the national organization and the state components. And I wanted everybody here to know that a lot of what we're seeing today and what we're talking about right now is because of some key initiatives that came from the American Dental Association. So we had a long-term care initiative that set in certain things. We're supposed to have goals, and we're actually meeting those goals. That's why we saw some data from Harry from the Office of Oral Health earlier today. So things are happening that support these goals. I was going to read with you really quick the emergency initiative, ER referral program initiative of the American Dental Association. So it's getting the right people the right care in the right setting. So if you look at some of the data here, they have total emergency room visits, 2.1 million in 2010 for dental reasons. 830,000 of those are for preventable dental conditions. 390,000 are from cavities as a primary diagnosis. So when we're talking about some of these visits not being truly urgent, that's what we're talking about, is people are going sometimes for toothaches, minor things, to the ER, and it's causing a big nationwide financial impact. So the ADA said we're going to institute ER interception programs in 25 states by 2015. Maryland should be proud. We're well on our way, not only with the work that Diane has done out in Western Maryland and all the Mission of Mercy projects, but also Frederick County's got something I'll share with you. We want to reduce ER dependency for patients with dental caries by 50% by 2020. Can we do it? I think when you look at Diane's numbers, I think it's possible. I'll talk with you a little bit about what Frederick's doing. So when we go out and we talk to the state components about these kind of things, supporting the initiative, and we talk about emergency room programs, it reminded me of some of the questions I heard this morning about where's the training for long-term care. There's no real training here either. There isn't a playbook. We're all trying to figure it out. And that's part of what we're here today to talk about, is getting the people in this room involved with your local ERs, with your local hospitals, share some of the successes that Diane and I have, some of the failures we've had, and take it from here, because we're all building data, we're all trying to have an impact. And when I got involved, I didn't really understand how this whole circle goes between getting, the patient comes in the hospital, but now it's going to be seen by a dentist. How do we get the dentist? Where's the money come from? So going through that learning curve for me was interesting. We ended up getting a grant from, the Community Action Agency, Frederick Community Action Agency, got the grant. They are not a FQHC, Federally Qualified Health Center. They have applied for lookalike status. Frederick doesn't have an FQHC. But they're the people that are able to go out there and get the funds. And so I've been a volunteer with them probably for 20 years, but they had these goals, and they were the person I reached out to say, we've got an opportunity to get some funding. Let's try to have an impact on emergency visits. So it started with me and Frederick talking to the people that could actually hold the funds, and next came the hospital. So we got, from our background, we got the grant from the Maryland Community Health Resource Commission. It's a 3-year grant. We were able to get about $240,000 total. And here are the priorities of this grant. Project priority areas: expanding access to dental care, that's what we're talking about. Provide alternative adult emergency dental services in outpatient settings. That's us getting dentists involved in the outpatient world. demonstrate medical-dental collaboration. So we had to show that we were going to be a team, that the medical side, the physicians, were going to be working with us and the dentists with them to get this done. And then obviously, we want to show a cost savings. If dentistry can show a cost savings to what's happening, it actually puts us on the map, so future considerations legislatively, politically, that we're considered to be part of that piece, and that's what we want to see. So I talked about some of the failures. Well, two of the areas where I ran into a conflict in our local in Frederick was, I remember calling Diane one day about it because I was starting to beat my head against the wall because I was dealing with an organization that really their goal was to provide comprehensive care. And we're trying to show that we can pull people out of the ER and give them relief from acute pain. So when you reach out to local organizations, you know, you're going to have to meet in the middle. Everybody has to play nice and try to show that we can have the best impact. FCA operates a health clinic, and they wanted to use the money for comp care. They had a waiting list. So once they were able to get this grant money, and I wanted to talk to the hospital and get patients out of the ER, they were like, well, wait a minute. We've got all of our in-house patients, so we want to do this first. One of the things that we did discuss was this community, the people that don't have access to care, don't have resources, they do talk to each other. And so once this program launched, even though it's not in the hospital, the ER started to see, we had patients coming to our office that were self-referring themselves to FCAA rather than go to the emergency room. So that's a piece of data that's not really measurable, but it is something that I saw quite often. And because FCA also was interested in making this a win-win deal, they interacted with the hospital. I sat in on meetings where we talked with Frederick Memorial Hospital, FMH, and informed them of the program, gave them referral forms. They were very engaged, very interested in moving forward. And I think a lot of that has to do with what Dr. Romaine was talking about earlier with certain things that happen in medicine and hospitals having caps on their ability to be profitable. They were no longer reimbursed on number of visits. So we weren't really competing with their income in their emergency departments. They didn't want to see these people because it was actually costing them money. So as we saw that landscape change, dentistry became probably more and more welcome to help. So the Community Action Dental Program, the one that I worked with in Frederick, they were taking referrals from their own primary care clinic, the emergency department, health department, private medical providers, and dental and other community agencies. So you can see that I was in competition. If I'm trying to show impact on the emergency department, I had other referral sources to compete with. So here's how it worked. Here's how we came up. Again, no playbook, but this is what we did, and it worked out well. Frederick County Dental Society recruited dentists and provide dental provider referral network. So I went out, myself and some other colleagues at the local dental society, made some phone calls, talked to some people that we know their heart's in the right place. It's amazing that some people, to me, would say, well, we don't have the people to help, and then you talk to the people and they say, well, I've never been asked. So sometimes it's just about asking people, and they will step up and do it. The patients, the way we work, the patients are going to be scheduled with the dentist by the Community Action Agency. So the patient would come from either one of those sources of referral or out of the emergency department, go to FCAA, they'd be screened, they would then be sent out to render treatment at a significantly reduced fee schedule. So what does that mean? Well, again, no playbook, so I talked to, what's the young lady's name at the health coordinator? Yeah, Dorian Burkholt. She came to a couple of our meetings. Again, talk about using all the tools that you have, talking to Diane with the Allegheny program. They sent Dorian over to talk to us, met with our people. So we're learning from each other as we do this. But we looked at fee schedules there. I talked to dentists, oral surgeons, general dentists, and said, show me a fee schedule that works for you, you know, maybe one of the lower ones, but, you know, we're not trying to, it's not a profit center, but we're also not trying to hurt you. So I started getting different numbers from people, and we came up with a fee schedule that the dentist could say, okay, I can do that. Again, nobody's trying to make money here. Nobody's, almost like a break-even thing is where the fee schedule came. And that's what we used. So our current statistics. Again, this program's only been running 4 months. So we started in April. Community Action Agency screened 249 patients. Only 37 of those came directly from the emergency department. Again, we can't measure those that word of mouth came through FCAA, but 37 directly from, meaning they came to the emergency department, they were handed a piece of paper that said, here's where you go. 80 individuals saw a general dentist. Well, you see that number, 169 visits, that's where comprehensive care starts to come in. So you can see that some of these visits are repeat. 17 individuals saw oral surgeons, 20 visits. Surgeons are usually in and out. They're not doing too many repeat visits. An endodontist, one saw a patient twice. So you look at our value. Again, what can dentistry do at the bottom line? Well, we were able to spend about $59,000 in the first year. And the value of the services, we asked the dentist, so when they turned in their report of the procedure, it was also report what your regular fee would be for that. So we were able to measure the difference between what we were actually spending versus what was the value we got. So you can see it's a little over double on what we're able to offer. So the local hospital reported this. I talked to them a few weeks ago. So we looked at last year from April to the end of July. They had 335 visits. So we looked at this year, April to end of July, 343 visits. That seems to correlate with the national trend of seeing numbers increase for dental reasons. The 37 direct referrals that came to our program are reflected in that 343 number. So what the hospital realized is a decrease in having to treat or screen patients because they now had an avenue. So although dental visits increased during the same time period, if you take the 37 referrals out, you see a decrease in patients who end up tying up time in the emergency room, not getting treated. We were talking earlier about what is an emergency department visit look like. I think nationally it averages around $600. And what's the patient get? They spend their day there. They get a prescription for narcotics, which we're trying to change, and they leave with the exact same problem they had. And the cost to the healthcare systems on average $600 to $700. So by taking these 37 patients out, the hospital said on average, because we had a quick screen, almost like a triage, we knew where to send them, cost them on average $67. So as Diane was explaining the HSCRC data, they looked back at the hospital in total and said that they can show a 10% drop. Since our program started, a 10% drop or a 10% impact on having our program live. So without a Mission of Mercy, with only 4 months running, we're already showing a 10% decrease. So dentistry can make a big difference. So are the challenges and opportunities that occur? Our year one funding is already exhausted. Community Action Agency has agreed next year to use the funds for urgent care only. They weren't happy the money ran out either. But back when we were starting this and they had their eye on the ball of comprehensive care, now they see all these patients that are now in the queue that they can't help because we were seeing repeat visits and doing comprehensive care. So they would like to see their dollars go farther next cycle. Our hospital in Frederick is in discussion right now, University of Maryland Dental School opening a clinic inside the hospital. This may occur maybe in the next year. That will have an impact obviously on the program, but that's getting into something that may be one of these sustainable programs. Certainly nothing that we worked on, but it would be a really nice thing to have that. We were talking earlier today about one of the things when you talk about data and some of the meetings I've been to with Dr. Romaine It's trying to get clean data is a real problem here. And our program, the way Frederick is run, the data isn't that clean because once the patient leaves the emergency room, goes to FCAA, goes to a dentist, they're not coming back to the emergency department to say, yeah, I got it taken care of, and here's what happened. So there's no loop closed. So sometimes that patient comes back again, and the emergency department's like, well, is this a drug abuser? Are they seeking pain meds, or were they never seen? So having some type of program that's more connected, or at least a liaison with the emergency department, really is helpful. Call to action, what you can do. CRISP, I don't think we talked too much about that, is Maryland State's Designated Health Information Exchange, stands for Chesapeake Regional Information System for our patients. And what that is a way for us to exchange information on the patients that come through the door. Dr. Romaine recently had her office manager sign your office up for this. And what they found, when I went on the website and when you look to register, you can go through a very onerous and lengthy application, or you can go to like a shortcut, and it's called the Prescription Drug Monitoring Program. So if you do that, you can simply sign up for that. A lot shorter application. Now if a patient comes in, emergency toothache, not a patient of record, you can go on to CRISP's website, put in their name, because you've signed up for the program, and you'll find out, is there drug-seeking behavior? Have they been bopping around offices looking for pain meds? So it's a way for us to talk to each other, and that's kind of nice. Coverage of our own patients' emergencies, that was discussed. Patient financing, using MSDA-endorsed vendor Care Credit. Another one, Springstone, where they do patient finance. So other things dentists can do is make financing affordable. And also getting involved with your local ED safety net. So this is really what we're talking. I've talked to you about what Frederick's done, but you're going to make your own recipe for what you're going to do. Learn from Dr. Romaine, learn from myself, get out there and do it. She talked about training ER physicians. I was surprised how receptive the ER physicians were to training. They don't get trained in screening. I've had them to my office follow me around learning injections because sometimes there isn't support, and they'll call and say, can I come over and learn this block or this infiltration or something, because they want to throw a couple of stitches in, and they're just not trained. I had a call a few months ago, a patient of mine playing college field hockey. She's wearing her mouth guard, but she got whacked with a stick, and out came number 8, and she's up in Pennsylvania in an emergency department. The physician calls me at 12:30 in the morning saying, what do I do? I don't have oral surgery support. So we talked about anesthetic, talked about reimplanting the tooth, not backwards. She did a great job. And I saw the lady the next day, or the young lady the next day, and the physician did a fantastic job. So sometimes they just want to learn, and that's what we're here for, is to plug those gaps, plug those holes where they don't have support. So if you're going to get involved, do that. Limit your narcotic prescription. I think Maryland I think it's October 1st, isn't it, that oxy drugs now have been moved up to Class 2. So you can see the federal push and the state push that's occurring where we're trying to limit narcotics. And all in all, as a going away message, we got to keep looking for sustainable programs, whether that's bringing back adult Medicaid, dental benefits, but we need to look at sustainable programs and talk to our supporters, leaders, politicians, and try to drive that forward. So thank you for your time.
We're here today to talk a little bit about trauma. I've got about 2 hours worth of stuff. I hope you'll tolerate some of my videos here. Meant to be about trauma. And I got involved with dental trauma in front of the projector here. I got involved with dental trauma many years ago when I did a residency over at Albert Einstein Medical Center in Philadelphia. It was a hospital-based endodontic residency program, so it gave me a lot of background in dental trauma. After that, I got involved with writing textbooks. Pathways to the Pulp is the most widely used endodontic textbook in the world. It's about 16 different languages. And I was asked to write a chapter in there on diagnosis, which I did. Subsequently, Mosby Elsevier got a hold of me and asked me if I would put together an entire textbook on dental trauma, which I did. So it's kind of a pet subject, and I think it's really relevant for a lot of us in private practice. I'm an endodontist in full-time private practice in Annapolis, Maryland. I've been doing this for about 30 years, nonstop. I started when I was about 12 years old, but I just aged really poorly. I have one office location. I'm there all the time, and I have 2 other endodontists that are there working with me. It's been a fun 30 years, and I think I have about another 30 years left since I have very young children. So I'll be practicing for a long time. But on dental trauma, let's go through a few things here. Fortunately, it's after lunch. This is the textbook that I put together a few years ago. It's put out by Mosby. It's in actually 4 different languages. It's in English, Spanish, Arabic, and Japanese. There's 11 chapters with about 17 different contributing authors. It was a fun project to work on. This is the new cover, not that you really care that much, but this is the new cover for the 11th edition of Pathways of the Pulp, which is not out yet, and nobody's seen this picture except for you. So don't you feel really special about that? What's really neat about this, not to dwell on it too much, although I want you to make sure you see my name up there, but this is in about 16 different languages, and it's the most popular endodontic textbook used in the world. It's one of Elsevier Mosby's largest seller. And what I had a problem with all the textbooks is that if you look at your textbooks, or if you can find any of your old textbooks, you'll see that there's clinical pictures on the front cover of it, or there's radiographs on the front cover of it, and everybody's critical about the pictures. Oh, well, it's a lousy angle, terrible photography. What kind of clinical case is this? And on endodontic textbooks, you know, they instrumented too much, it's an overfill. So what I did was to take an image from here to here on what's known as a micro CT. Most of us are now more familiar with CAT scans and CTs. It gives you slices through things. Well, in our typical cone beams, which I imagine a couple of you have in here, on a typical cone beam, your slices are every 75 microns. You know, that's on a pretty good system. The slices that you can take on a micro CT for some great investigative work is about 6 microns. So it's really, really small. This image from here to here is an actual micro CT of a root of a tooth. This is really what they look like. It's not just 3 canals. It's pretty cool. So what we did is we superimposed that on some nice graphic art to make it look kind of real. But nobody can criticize this because that's really how it is. Anyhow, the textbook that I have has 11 different chapters, and we can't cover all of them today, and they would put you to sleep a little bit more than you already are right now. But we're going to talk basically on assessment, crown fractures, intra-alveolar root fractures, luxations, avulsions, and then we're going to skip down to prevention. We have a lot to cover in a very short period of time. To try to keep you aware of where we are in the presentation, or in case you decide you want to fall asleep, when you wake up, you'll see an outline at the very top that will address all the different topics, and it will highlight where we are in case you get lost. As defined, the branch of dentistry of dental traumatology is the epidemiology, the etiology, the prevention, assessment, diagnosis, and management of trauma of the jaws and the surrounding tissues. It occurs mostly in children, mostly in younger children, and it's kind of an equal incidence among young boys and girls, the really young ones, because they're just about as busy as each other. But in older children, it seems that these injuries are more so in boys because they tend to be a little bit more sports related. Predetermining factors. the lack of natural protection. If you have an 8-year-old, if you've seen a few 8-year-olds, you'll see that there's usually a pretty good overjet here. So when these kids land on their face, guess what they're landing on? They're landing on their teeth. So the lack of a natural protection is one of the predetermining factors. And acute medical issues. If if you're seizure prone or if you have a heart attack, sometimes you'll have some dental trauma from that also. General anesthetic, I think a lot of us have heard about the incidences where somebody's intubated and it might luxate a tooth. And socioeconomic, I mean, there's a little bit more abuse and assaults and lack of supervision in our lower socioeconomic classes. Sports-related is the most common cause of dental trauma behind just simply falling down. The other day, my wife walked into an open shower door. The lights were off, and of course, it was my fault. But things like that can happen. And again, the predetermining factor is because of the overjet that you have in these 6 to 10-year-olds, 11-year-olds. These injuries that you can have would include crown fractures, root fractures, luxation injuries, avulsions, soft tissue problems, alveolar fractures. And the implications have to do with the function, cosmetics, and certainly the emotional and psychological effects that you can have from these types of injuries. The approach to managing these injuries really should be multi-interdisciplinary, involving pedodontists, endodontists, periodontists, oral surgeons, sometimes plastic surgeons, and sometimes a psychiatrist. The dilemma is that a lot of times when these injuries happen, like at 12:30 in the morning that I heard about, I'm not sure why the phone call came at 12:30 in the morning when it was a lacrosse injury, but it was probably in college or something, and we don't have to talk about what happens between 4 o'clock and 12:30 in the morning. But it's usually a sudden, quick, and an unexpected injury. Managing children, boy, it can be really difficult. There's volumes of research on dental trauma, tons of it. And a lot of confusion over some of the past studies, because some of them are anecdotal, just from people telling incidences that happen and get it published in a non-peer-reviewed magazine. And some of them are in peer-reviewed journals and are just really hard to figure out. There's some confusion over the procedure that we would do and what materials we should use. So my goal today is to put all this together, and if it gives you something that you can take home with you that you can better manage your cases, that's what it's all about. There are some great guidelines that are out. There's a guideline out that in 2012 from the AAE. But there's also a publication that you have in front of you from a newsletter that the American Association of Endodontists puts out, and it's called Colleagues for Excellence. And it's a 2014 compilation of everything I'm going to talk about today. So you can get to a certain heading, and you can figure out exactly what you should do, or you can just call me on the phone. So let's talk about assessment. And if you notice, we're still at the beginning over here. When the patient comes in, of course, you want to get a good medical history. You want to get a good initial and dental assessment of what's going on so you can manage that. Find out what the trauma history is. That's kind of important because if somebody has repeated traumatic injuries, what are you thinking about? Abuse. And it's so much more in the public's eye these days. Gross clinical appearance of how the person looks, and certainly a soft tissue examination is very important just as much as a hard tissue examination. Medical emergencies, what about the cause of that trauma? What about respiratory or cardiac issues that may be involved? What about neurologic issues? These are all things that we need to think about in our medical assessment of the patient. Recent hospitalizations can tell you a lot. Because if all of a sudden somebody says or puts on their history form, yeah, I was in the hospital last week, well, a red flag should go off. Something happened, they went to the hospital. So recent hospitalizations and the record of that can give you a lot of guidance on how to manage those patients medically. And certain allergies and systemic diseases are important to understand. They're all good screening questions. We overlook it, but vital signs are very important. Certainly if the person has some type of respiratory distress, they're having a tough time breathing, that's not a good thing. And sometimes the dental problem has to take the back seat. Sometimes the dental problem is the cause of the respiratory distress. So it's something that needs to be assessed very carefully. Excessive bleeding, you know, a little bit of blood in the mouth with saliva looks like a lot of blood. So you want to try to control it, find out where it's coming from, and make sure the person isn't in any kind of distress. You better make sure that patient's responsive, because if they've had a traumatic injury where they have some head and neck injury going on there, you want to make sure that they're not going to arrest in your office or have some other problem. So dentistry is important. Making sure they stay alive, that's pretty important too. A cursory neurologic assessment to recognize medical crisis. There's something called a Glasgow Coma scale, and that's to determine the possible extent of brain injury. And it sounds really simple, and we kind of do it anyhow, but at least it has a numerical value attached to it, so you can make that assessment a little bit easier. And it has to do with how well they open their eyes, how they focus, verbal commands, how their responsiveness is to certain commands, asking them to do various things. And you might not be able to read this all that well, but on this test, you want to get a low score. It's kind of like golf. Eye-opening, whether they can do it spontaneous or not, to verbal commands, no pain, where there's none as far as eye openings go. I'm sorry. Lower scores indicate a more severe brain injury. I was thinking about the way that I play golf. Verbal responsiveness, are they confused? Is there no verbal responsiveness at all? Motor responsiveness, do they have no motor responsiveness, or are they obeying what you ask them to do? So it's all simple stuff, but it's something we have to think about to make sure that they're not having any other types of neurologic crisis. Potential intracranial injury if there's disorientation, seizures, amnesia, nausea and vomiting, that's a big one. And you know, they tend to look like this. It's not a happy thing to see. You want to look at the gross clinical appearance. What's going on here? They can't open their eye. There's some swelling over on this side and some bruising. Take a good look at that and assess it, because it may be asked later, well, how did they look when they came into your office? Control excessive bleeding. You're going to have to do that a lot, especially trauma to the lips and to the teeth. There can be a lot of bleeding. You got to figure out where it's coming from. Look for asymmetry. Sometimes when you have a right orbit fracture, the fat pads, if you will, underneath of the eye will slip through into those cracks on the bottom of the orbit, and the eye will tend to sag down a little bit. So those are things that you might want to look at when you're trying to assess the patient. Look for symmetry. That's what we do all day long, looking inside the teeth. We look for symmetry. That's what you want to look for when there's a traumatic injury also. Potential basal skull fractures. There's something called battle sign, and that's when you have bruising behind the ear. It can be bilateral around the eyes. Sometimes they call that raccoon eyes. A nosebleed, bleeding from the ears. These aren't good things, and that's called different signs that are called battle signs. If you notice, if you can see it on the bottom right-hand corner of the screen are references. I give this presentation to residents, and sometimes they're really interested where this stuff came from. Initial dental and medical management. Remove potential airway obstructions, certainly removable prostheses. Locate fractured or avulsed teeth. It's kind of important. Sometimes they're actually in the lip itself. So you want to feel around and do a good assessment. It might not be on the playground field. Severe intraoral bleeding, again, we need to control that. And the patient's history of trauma is important because it all has to do with the prognosis assessment. Where did it happen? Was there bacterial contamination on that tooth that's inside in your hand? When did it happen? Because the prognosis, the success rate for repairing teeth that have been avulsed, knocked out of the mouth, the timing is very important, and we'll discuss that later on. How did it actually happen? The severity of the trauma and the expectations from the other injuries. If somebody was in a car accident, there may be other injuries than just a tooth that was knocked out. So all these different parameters are very important. And you want to beware of intentional injuries, self-inflicted injuries, child abuse, domestic violence, all very, very important. You know, the soft tissue injuries are really hard to take care of. They usually exhibit a lot of bleeding and they're hard to get under control. Most of us should feel pretty comfortable managing some of these simple wounds, but we'll talk about soft tissue management later on also. But you want to control the bleeding so you can assess what's going on. Digital pressure and local anesthetic with epinephrine, very helpful. Lacerations, potential embedded foreign objects, like a tooth. Radiographs are very important also. Sometimes you get fooled. There's a whole lot more going on, and the radiographic assessment is very, very important. Extraoral hard tissue injuries and assessment of intraoral soft tissues. Alveolar fractures certainly come into mind. A lot of times you can feel that. You can feel the discrepancy for where that fracture actually is. And if the person normally had a normal occlusion and now they can't put their teeth together, there's something else going on there. And it might be a tooth that was extruded, or it might be a jaw fracture. So occlusion and severe malocclusion that wasn't there before, very important in your assessment. And certainly interarch alignment, like I spoke about. There's some interesting signs of alveolar fractures that you can see intraorally when you look at the soft tissues. You can palpate those areas also to try to feel fractures underneath. And if you have bleeding in an area like that doesn't look like it should be a spot that should bleed that much, start thinking along the lines that there might be a fracture underneath of that. Tooth assessment, that's what we do best. Missing or displaced teeth, localized pain. It may be a tooth that was intruded all the way up. It might be a tooth that was knocked out. And again, that tooth might be someplace else in that mouth. Clinical tooth assessment. You're looking for symmetry. We do that well, especially for missing or displaced teeth. Percussion can tell you if there's an injury pretty quick. And certainly if there's mobility. It's really hard to tell mobility. If you go in there with your fingers, sometimes it's really hard to tell if that tooth is truly loose or not. But if you get two dental instruments on either side of that tooth and try to wiggle, 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 wasn't that Snoop Dogg? Sometimes you can see that tooth move, sorry, just a little bit more. There's something called a perio test, which also gives you a digital readout as far as how mobile a tooth is. But you don't see the perio test very often. Crown fractures and transillumination, excellent way of looking to see if there's any crazed lines or cracks that may have been there before but may have developed from the traumatic injury. Pulp exposure, my favorite topic. We can see that pretty easily, and we'll talk about that. But let's talk about vitality a little bit before we go into too much more. A word on pulp testing after trauma. It can be really variable and very misleading as far as trying to pulp test a tooth that had a traumatic injury. If you have an immature tooth, there's a certain set of nerves that are inside the tooth, and they don't really respond to electric pulp tests or cold very well. And sometimes it takes about 4 years. Sensitivity only after root development for about 4 years. So in a really young patient, especially for an immature tooth, you might not be able to get a decent vitality test on that tooth. And also because of the large vascularity, that large pulp supply on some of these immature teeth, a lot of times that pulp tissue is more inclined to stay vital. We're not talking about avulsions, but we're talking about teeth that have been knocked around pretty well. On mature teeth, it's also a variable response. You can check initially, but if it tells you the tooth is non-vital and you know it's had a really good knock, I'm not talking about an avulsion, but a tooth that's been kind of hit pretty hard, it might take a couple of months for that tooth to be able to sense your vitality reasons. So you have to assess this really very carefully, but don't hold a lot of water on your vitality testings, at least not right away, especially when we're looking at mature teeth. Thermal tests and electric pulp tests. Notice I didn't have heat tests on there. Most of the endodontists aren't using heat that much. Heat tests don't help us much. I'll digress a little bit. Patient comes into your office and they say, "Oh, doc, something back there is killing me. I don't know where it's coming from." And you say, "Well, what bothers you?" "I had coffee this morning. Killed me. It took like an hour for it to get back to normal." Are you going to heat test these teeth? No. One of the things that's really unique about endodontic problems is if you have a tooth where the pulp inside there is non-vital, when it gets infected, when it gets warm, it causes a lot of pain. So how are you going to find out which tooth it's coming from? Well, if the patient's in pain when they come in, you put cold on the various teeth. You find that one tooth where the pain goes away. You found the non-vital tooth. So it's a nice little trick for you. As far as cold testing goes, what do we use for cold test? Ice? No ice? Endo ice? Freon. And these formulations that are a lot like Freon. There's something called Endo Ice. It's a can of spray that you can spray on a cotton tip applicator. It's very, very cold, like minus 30 degrees. It's expensive. You can go to Radio Shack and get Circuit Freezer Coolant. It's exactly the same thing, and it's about a quarter as expensive. And you can use that and spray that on a cotton tip applicator, and you can use that to check the vitality of the tooth, or like the case I just mentioned, the non-vitality of the tooth. Circuit Freezer Coolant at Radio Shack. Works great for a cold test. The problem with ice, or putting water inside of a carpule and putting it in the freezer, is ice melts. And if you have a tooth adjacent to a tooth that you're having a problem with, it may stimulate that tooth too. It may get on the gingiva and change what the patient's actually sensing. So try to stay away from ice. Try to use something that is like a spray, like Freon, like Circuit Freezer Coolant. Ethyl chloride can also be used. It tastes terrible, and it doesn't stay cold for very long. So end of digression. There's something also called laser Doppler flowmetry. It measures blood flow. And these machines have been modified in order to check the blood flow through a tooth. So there is some potential as far as that goes. Of course, it would not work on a tooth that had a crown on there. Pulse oximetry, also some great future potential as far as vitality tests. It tests the oxygen saturation in your vasculature through certain LEDs and sensors. And there's a lot of potential in that too, especially for traumatic injuries. But you need a specialized probe, a probe similar to this that would be custom designed for teeth that you can actually sense the oxygenation of the pulp inside that tooth. That is the next phase for pulp testing, and it would be a great test for these cases where the nerves might be damaged, might not respond to pulp testing, but if their tooth certainly has vascularization in it, you know you're in pretty good shape here. It's almost 100% accurate. Then our radiographic assessment, very, very important. In cases like that, you may be able to see fractures, and you can also see maybe there's a tooth that has an underdeveloped apex. But you need multiple angles. The stage of root development is very important. You could take this radiograph up here at a couple different angles, and you might not see that fracture at all. So for traumatic injuries, don't rely on just one radiograph. Take a couple, take 3. Make sure you know exactly what's going on. And if you have a CBCT in your office or have availability to it, that would be great also. Crown or root fracture sometimes can be determined on a radiograph, and the degree of luxation that you have, how loose that tooth is, a very important assessment to have. Oftentimes you'll notice the periodontal ligament can change. Obviously, if a tooth is extruded a little bit, that periodontal ligament is going to look really wide. If you have an intrusion injury, you're going to compress that PDL, and you might not see that periodontal ligament at all in a radiograph. So assess the PDL thickness also, or lack thereof in intrusion cases. Extraoral radiographs, sometimes they're important to do also, because sometimes we can't take them real well in kids. And I think I have, yeah. This is a technique that you might not have used very much, but if you have especially a child, that you really can't get a radiograph film inside their mouth or a sensor, you can actually put it on the outside surface of their cheek and be very creative to get your X-ray beam about 90 degrees to that. And surprisingly, you can get a pretty good picture. So don't forget about this. This is a nice way to go too. Important to follow up after your traumatic injury has been taken care of. You want to look for external resorption. External resorption is a lot of different kinds. There's something called surface resorption, which happens on all of our teeth. There's always a little bit of dents in our cementum. There's something called replacement resorption. That's where the bone actually infuses into the root of the tooth. The bone actually replaces the root of the tooth. It's caused by injury to that periodontal ligament around the root of the tooth. And many of you have seen this, because when you go around on your teeth and you tap on your teeth, you hear something like that. When you hit a tooth that has ankylosis, where it's part of your skull, then you get this solid sound, and it's really, really different. So when we talk about something being audibly ankylosed, you hear a ping, ping, ping when you're touching your other adjacent teeth. But when you hit that tooth, you feel like that whole jaw is rocking in there. That's usually a tooth that's ankylosed, and that's not a good thing. And we'll talk about that later also. But that's when the bone fuses to the root of the tooth. There's inflammatory resorption, where the tooth is seen as being something really foreign, and your bone says, we don't like this at all, and it comes in with a lot of inflammatory cells and eats away the root of the tooth very fast. This is a popular way of external resorption that we see on teeth that have been avulsed, knocked out of the mouth. Then there's cervical invasive resorption. It's a type of resorption that we think might have something to do with trauma. Maybe it has to do with orthodontics. Maybe it's all of the above. But it's an aggressive resorption cervically around the tooth itself, where you have a gross amount of tooth structure that's dissolved over a very short period of time. Very difficult to manage on so many different interdisciplinary approaches. And then, of course, we have something called internal resorption, where there's inflammatory cells inside the pulp that says, we've been injured, we don't like it, and we're getting out of here. And it starts to overgrow the inside of the pulp at the expense of the inside of the root of the tooth. Left alone, you won't have any root left. So that's internal resorption. And of course, in your follow-up, you want to check the vitality of the tooth in question if it hasn't been endodontically treated yet, and you want to check the vitality of the adjacent teeth also. Any questions at this point on assessment? Moving right along, see that? Crown fractures. Now we're getting into some real dentistry here. Here are the three basic types of crown fractures, and they've changed as far as the terminology over the years, but it's all pretty much the same thing. You have enamel and fractions, which are also called Kray's lines in the enamel. You have an uncomplicated crown fracture and a complicated crown fracture. That doesn't sound too complicated. The uncomplicated crown fracture is a fracture of your enamel and dentin. It's not into the pulp. A complicated crown fracture is when your fracture goes into the pulp. It's very simple, no classifications to remember. It's complicated or uncomplicated. They all relate to different symptoms, clinical presentations, and you manage them differently depending on whether that tooth has a mature or an immature root, and how to manage these cases. They're all different also. Enamel infractions, probably most of us in this room have some sort of that or another. Hairline, superficial crack, they're asymptomatic, and they usually just pose cosmetic problems. There are little lines in the tooth, and if you put some light behind it and transilluminate it, sometimes you'll see those cracks. Sometimes those cracks will be highlighted a little bit more if there's a lot of standing from coffee or tea or smoking, but it usually doesn't cause us too much aggravation there. But let's talk about uncomplicated crown fractures. And again, we used to call that an Ellis-1 or an Ellis-2 crown fractures, whether they were a fracture of just the enamel or the enamel and the dentin. But now the terminology that's used by the pedodontist is an uncomplicated crown fracture. It's just the enamel and the dentin. There is no pulp exposure. Now, most of the time, on these uncomplicated crown fractures, we do nothing, especially on a case that has an immature root of the tooth. And if you look at that, hey, the one next to it, that's immature also. So you're in good shape. You've got some symmetry there. Both of these two teeth are at the same developmental level. Whether you can test this tooth and get a vital response, which you won't be able to or not, in cases like this, you just want to treat this cosmetically. And I'm sure most of you have seen that the person who's really upset about this is usually the parent. The kid walks around, they think this is pretty cool, look what happened to me. On a complicated crown fracture, though, a little bit of a different story. It was considered the old Ellis Class 3 fracture, and that's when you have an enamel and dentin fracture, but with a pulp exposure, and you can usually see a little red dot there. And sometimes you're not really sure if that's a pulp exposure. You dry it off a little bit, you're not sure if it's blood from the lip that's up there, but you can touch it with an Explorer, and you won't do that again. So that's a pulp exposure. That's what you're going to see there. Now, you're going to manage pulp exposures one of two different ways, and it depends on the maturation of the root of the tooth. A pulp exposure for a mature apex, do you do endodontics? Usually, yes, especially around the end of the month when the mortgage payment's due. So usually it's yes, unless there's a wide canal space. So if it's a pulp exposure and the apex is more or less closed and the patient is 13 years old, but the pulp canal space there is really wide, you want that to develop. You want that to calcify in as best you can. So you'll consider pulp capping that pulp exposure on a tooth like that. Try to stay away from endodontic treatment if you can, because you want the root of the tooth to grow more. Now, in the past, we've used calcium hydroxide, DiCal, to pulp cap these cases. I would hope that most of you have heard of mineral trioxide aggregate, MTA. It's also sold as ProRoot. It's been around so long that it's now available in more of a generic form since the patents have run out from Tulsa Dentsply. But MTA, mineral trioxide aggregate, is a wonderful material. It's powdered, medical grade Portland cement. That's what it is. The great thing about Portland cement, the stuff we put our basketball poles in the ground with, is that it sets up under a moist environment. And guess what? The pulp is kind of moist. What works really well is when you put this on an exposed pulp, not only would you get a nice bridge formation of a calcium bridge underneath of that, the pulp continues to grow normally. It's a wonderful thing. In the past, when we've pulp capped with calcium hydroxide, what you end up seeing is a much more rapid calcification of the canal space. So it's not unusual to have a pulp cap on a tooth and on that particular tooth see a gross amount of canal calcification compared to the adjacent teeth. Well, what would be the problem with doing that in a case like this? Well, if you've got 8 and 9 and one has a pulp cap, and you use calcium hydroxide, and you get a tremendous amount of calcification, A, if you needed to do a root canal, which you might not, it would be really hard, but B, what gives our teeth their color? Some of the pulp underneath of that. So if you have a tremendous amount of calcification inside a canal space, especially in a pulp chamber, that's going to cause that tooth to become very yellow looking. Not tanner brown like you'd have on a non-vital pulp, but very yellow. MTA is a wonderful thing, and it comes in a yellow, whitish powder form. You mix it with some water, and you just put it right over that pulp cap, and then you put composite over top of that. And it will allow that pulp tissue to remain vital. The companies that are out there that sell it are Tulsa Dentsply, sold as mineral trioxide aggregate, ProRoot, they also call it. You can also get the MTA through Henry Schein now, very reasonably priced, about a third of what Tulsa sells it for. It's exactly the same thing, and it's MTA Angeles. It comes from Brazil. And then there's another great product out there called Biodentin. It comes in carpules, like your old amalgam carpules are, and it you put your solution in there, you put the cap back on, and you put it in your triturator that you might not have used for a while. And it comes out as more of a putty form, and it's very white. It works very, very well. It sets up faster than MTA does because it has calcium chloride in the water. So if you mix calcium chloride and the MTA, it sets up really fast. Biodentin knew about this. It's put out by Septodont, the same people that have Septicane. It's a great product, yes.
Is it an MTA though?
The question was, is Biodentin an MTA? Yes and no. The active ingredient, don't you hate it when people say yes and no? The active ingredient in MTA is something called a tricalcium silicate. And that's what Biodentin is. It's a tricalcium silicate, which is the active ingredient in MTA that makes it do what it's supposed to do. So the Biodentin is really good. I will tell you that it has the same radioopacity as dentin. It doesn't have much more radioopacity, where the MTA has more. Good or bad, it's something to think about. A lot of the endodontists are using Biodentin as their retrograde filling material. A great product that's on the market, and it's about a third the cost of ProRoot MTA as offered by Tulsa Dentsply. Now that becomes very important on a tooth with an immature apex. keeping in mind that the vitality that's lost on a tooth with a pulp exposure happens over a period of time, and it happens to be about 2 millimeters a month. So it wouldn't be unusual for somebody to come in with a pulp exposure from a traumatic injury, a complicated crown fracture, and have you feel that and still have vitality to it. Because it takes about a month to lose about 2 millimeters of that vitality. That's a good thing. The pulp does not die that fast. So what you can do in a case like that is to do something that we used to call a partial pulpotomy. The pedodontists would call it a spheck pulpotomy. And in a case like that, what you do is you anesthetize the patient, and you go in with a round burr only about 2, 3, 4 millimeters. You don't do a pulpotomy because you want to try to keep as much of that pulp alive as you can. So you do a partial pulpotomy, just a few millimeters into it with a round burr, wash it out with some saline, put some MTA in there, and then some composite over top of that. You want to keep the radicular pulp, the pulp tissue inside the root of the tooth, alive. So a pulp capping is a great way to go, especially for these immature teeth, because when they become non-vital, they're much more difficult to manage. Yes?
Do you use anything like chlorhexidine before you apply this, or just saline?
Do we use chlorhexidine before we apply the MTA, or do we just use saline? No, we don't use any chlorhexidine. One of the problems with the chlorhexidine, although it's a great antiseptic, is it can have the tendency to discolor a tooth. We try to stay away from that. No, you really don't have to, and you don't have to use sodium hypochlorite either. You know, the great thing about MTA, as long as you brought this up, I wasn't going to talk about it, but one of the great things about MTA is, what do you think the byproduct is of MTA setting? It's calcium hydroxide. It's pH of about 12. So it has its own antiseptic effect to it. And again, because of the high pH of that, it tends to help us out as far as the calcification goes. So we're getting the benefits of the calcium hydroxide without the dical and using something that seems to work very, very well.
So just saline?
Just saline. Wash it out and put the MTA on top of there. Good question. Yes? The question was, what about diode lasers to do pulpotomies? That's a whole lecture on itself. The diode lasers are excellent for more or less searing that pulp tissue and making it work, making a pulpotomy work. Unfortunately, in the peer-reviewed literature, there's not a lot of good stuff on that, or the YAG laser. The use of lasers in endodontics has been suggested by a lot of people. There's a cost factor involved. A lot of people don't have them. And the studies are looking fair. They're a great way for disinfecting. It's not great as much as a lot of the laser people think. But in the peer-reviewed studies, it's looking pretty good. As a digression, lasers will not replace a root canal cleaning. They go in a straight line. They don't go in a curved line. But the thought of going in there with a laser to access the pulp and then be able to go up inside the root of the tooth and disinfect the pulp tissue, it ain't going to happen. And it's not going to happen with lasers either. When we do our root canals, you saw the picture from the very first slide, we're lucky if we can touch 50% of the pulp tissue inside there. And with lasers not really going anywhere but more or less straight and not much further from that, it's not going to help us out as far as root canals go. There's a lot of really cool things that are out there to help disinfect root canal systems. Lasers has been one of the things that have been brought up, but it hasn't given us a great response in our peer-reviewed literature on studies that have been done on it. There will be another device that will come out. Nobody knows about it except for the people in this room. And it will be a way of disinfecting the insides of root canal systems without using chemicals, without using bleach, without using lasers. You'll be opening up your canal systems to about a size 25, and then you're going to put something in there, and it's going to disinfect everything that's inside the canal system. And you're not going to hear about what it is for another 6 months, and I can't tell you. No, I can't tell you. Well, you pull my leg. No. No, I really can't tell you. But things are changing a lot. The big thing in endo has been how we clean and shape our canals. And with the rotary-driven files that we have, the nickel titanium files, they're pretty darn good. As far as filling the insides of the roots, we use the worst filling material in all of dentistry, but there's something pretty cool coming out for that too. Yes?
Proprietary stuff for you?
No. but I'm doing some consulting work for a company that's out in Missoula, Montana. And they're working on this. This is a great digression. I don't want to take up too much of your time. But I was flown out to Missoula, Montana, and I was asked to give a presentation to 4 people. The president of the company, a metallurgist, an electrical engineer, and a physicist. Not a dentist in the room. And they said, we want you to tell me everything there is to know about how you clean, shape, and disinfect a root canal system. And I gave them 3 hours straight through, and they're just sitting here looking at me the whole time. They understood everything I was talking about. They knew what was going on. And then I was all done, and I said, that's it. They looked at each other and gave each other high fives. And then they told me what they had. And I know my field pretty well. And I've done a lot of consulting work, especially for Dentsply and Tulsa Dental. I know what's out there. I know what's coming. There's nothing like this. It's a way of disinfecting that has never been used in medicine or dentistry. And I think it's going to be something really pretty cool. Yes?
Are you going to be doing a presentation for this new product line?
Probably will.
Are you going to give the MSDA some information as to when
If they ask me to, I will. And I wouldn't be surprised if this particular company would help to sponsor some of the presentation too. This is a huge company that's based out there, and they've already put several $1 million into this. When I saw them, the product was the size of a large laptop, and I got the prototype last week. And it's the size of a handheld instrument that's rechargeable. So it's pretty cool. Can't tell you anymore. All right. But endodontics has to keep up with you-know-what? Implants. And our success rate is as good as implants as long as it's done well. But we have to make sure we keep ourselves focused in that area. Anyhow, an immature apex and a crown fracture, how are we going to treat that? MTA. We'll do an MTA pulpotomy on that. You have the fracture. MTA used to be kind of gray. It's white, yellow now. It's packed on top of that tooth, and the root of the tooth would continue to grow over time. So if here is a tooth with an immature apex, here we are a year later. It really, really works, and that pulp is vital. And you probably don't need to do anything with it. Here's another tooth here with a complicated crown fracture, but it had been fractured for a long period of time. So we got down to where we got vital pulp, filled that with MTA, and again, the root of the tooth continued to develop. So take advantage of the materials that are out there. Try to keep that canal space growing and forming over a period of time. When a pulp does not remain vital, and the apex is not closed, a non-vital immature tooth, you're going to need to do something called an apexification. There's a traditional and there's an MTA apexification. Traditionally, we've used calcium hydroxide to do our apexifications. What we would do is we would have a tooth with an immature apex, sorry, over here, and all the tissue inside there is dead. It's infected, there's some swelling, periapical lesion, if you will. You go in there with an endodontic file and you clean out as much of that dead infected tissue as you can. And then what you do is you fill up the entire canal with a calcium hydroxide paste. It's not Di-Cal. We actually had powdered calcium hydroxide that you can mix with saline or water or anesthetic solution. And you can pack that up inside there. You can pack it up with the back end of a paper point, but you want to get the calcium hydroxide all the way up there. Now what that does is it gets up there around the very tip of the root of the tooth, and right where that interface is and vital tissue is, it forms a calcific bridge. And believe it or not, the calcium that goes into that bridge does not come from the calcium hydroxide. It comes from your serous fluids over there. You end up creating a calcified bridge at the very end of the root of the tooth. And then what you can do is you have now a definite stop and maybe even a little bit more root formation, and then you can fill that back up again, either vertically or laterally, to fill up that spot. The calcium hydroxide medication that you put inside the tooth, you have to do it, wash it out another couple of months later and do it again. And sometimes it can stretch out over a period of a year until you get that definitive stop at the end of the root of the tooth. It's a very long and protracted way of dealing with this, especially with young kids that might not be as accessible. There's another way of doing this. It's been around for many years, first written in the Journal of Endodontics in 2008. And what we do is this. We clean out the inside of the root completely, like we did before. This is all non-vital tissue and there's a lesion. We measure how long it is from here to here, to the tip of the root of the tooth, and we place in there a thick mix of MTA. Remember, it's a powder, a lot like talcum powder as far as consistency goes. You mix it with water or saline or anesthetic solution, and you pack it up inside there with a vertical plugger. Try not to let it go periapically, but it's okay if it does. And you want to try to get maybe 3 or 4 millimeters of that so you have a nice definitive stop of MTA. Hard to manipulate, but it works really well. Then after you do that, you can either fill the remainder of the canal space either with more MTA if you want to, because you're never going back in there again, or you can fill it up with warm gutta percha and pack it up inside there. Some people have advocated putting dentin bonding composites in there to help strengthen the root of the tooth. That is an outstanding way of doing a one-visit apexification. It works very, very well. Pediatric considerations, the sphex pulpotomy or the MTA pulp cap, very important, and then restore the teeth. Not much to talk about there. There's something else that we may talk about later if we have time called pulpal regeneration. Anybody heard that term before? What you do is you go up inside the tooth and on a non-vital tooth and you induce bleeding. You induce bleeding by going periapically. You sterilize the inside of the tooth using multiple washes with multiple different antibiotics. There's 3 of them that are very popular. And then you let that bleed. You cap over the coronal part of it with MTA and new pulp tissue forms. It's really not pulp tissue, but they call it pulp tissue. It's more of an osteodentin, but at least the tooth it becomes viable. A nice way to go. Any questions on crown fractures? Yes?
For the calcium hydroxide calcification, what's the time frame for calcification?
Time frame for?
The root end calcification.
For MTA apexification? Okay, the question is for a calcium hydroxide traditional apexification, you can get an apical bridge to form there sometimes in a couple of months, but you have to keep checking it. Sometimes it can be a year before you get any kind of apical stop there. Okay? Intraalveolar root fractures. This is a really fun topic, believe it or not, and of the 11 chapters that are in the dental traumatology textbook, this is a chapter that I wrote. I've got a lot of cases on this, but they're very interesting as far as how to manage them. An intraalveolar root fracture is a fracture that goes through the root and is in the bone. I'm not talking about a vertical fracture like that. I'm talking about one that's more horizontal to more oblique and in the bone. This is what the tooth might look like out of the socket. It's usually oblique. It's rare that it's really horizontal. And again, because of the angulations that can be taken radiographically, sometimes you'll see it, but if you foreshorten this, you might not see it at all. There's a coronal fragment and an apical fragment. So those will be the things that we'll be discussing. Obviously, the coronal fragment is here, and the apical fragment is there. The fracture may be in the coronal third. It may be in the middle third. You can see that right there. And finally, it can certainly be in the apical third of the root of the tooth. The lower it is, the closer to the apex that horizontal root fracture is, the better the prognosis is going to be. Because obviously in a case like this, you don't really have much to work with the coronal or the apical segments there. It's difficult to diagnose. You need multiple radiographs like I talked about before. And again, this is the same patient, and you can see maybe in hindsight, maybe a fracture there, but obviously the fracture is there. So multiple angles are very important. It may appear as multiple fractures. That doesn't usually happen. The reason why it looks like multiple fractures is because you have a break here and a break there, and if your radiographic film or sensor is on that side, it's going to look like a halo or multiple fractures. It's just because it's more oblique than it is horizontal. Typically, the presentation is that it might not have any mobility or it might have a lot of mobility. It depends on where the fracture location is. If that fracture is apical, you're not going to get much mobility at all. If it's coronal, you're going to see a lot of mobility and certainly a lot of sulcular bleeding in there also. Sometimes you'll see it as a slight extrusion of the tooth when there's a root fracture because it's come down from the root system itself. Surprisingly, most of these teeth with horizontal root fractures remain vital. So typically it only becomes non-vital about 20% of the time. You'll have better healing if it's more apical, if the fragments are in closer proximity, and if it's on an immature tooth, which is also much more vascular. So just because you see a root fracture like that, don't be ready to jump in and do a root canal, because most of these, especially if you have good approximation of the fragments, especially if it's more apical, they remain vital. So just follow them up over a period of time. Here's a case here where there is a root fracture right there. It's an immature-ish kind of a tooth, and you can see over a period of time that that fracture is actually healed beautifully compared to here. Here you can see this is from a previous trauma where that's continued to grow also. So leave them alone. Healing. Sometimes you'll get the healing in those fractures with a calcified fusion that actually grows between the two. Sometimes you can get connective tissue that can grow between the fragments. Sometimes you can actually have a wide enough spread that you'll see bone growing between the fragments. Non-healing is a different story, and this is a pretty typical presentation for non-healing for a horizontal root fracture. The pieces are far apart from each other. The coronal fragment is probably non-vital. Notice there's not much of a lesion there, but it's at the junction where the fracture was. And that's because the coronal fragment tends to go non-vital when it does go non-vital, and the apical fragments tend to remain vital. We'll go over that. Management. Reposition that tooth, splint it if necessary, and again, endodontics is usually not necessary, but if it is necessary, treat the coronal fragment only. The apical fragment tends to remain vital. And that has been validated by only a couple of different studies where they've actually done histology on the apical fragments, and there's vital tissue inside them. So in a case like this, where there's a horizontal root fracture and swelling and a lesion there, you try to get your best measurement of what the working length would be of the coronal fragment. You clean that out. You can put MTA in there or gutta percha if you can. And it works almost all the time. But sometimes it doesn't. Yes?
So that's if it's an apical fracture or in the middle?
It doesn't matter. Whether it's apical, mid-root, you only want to treat the coronal fragment. Okay, you leave the apical fragment alone.
Okay, and then if you've got mobility because it's in the coronal third.
If you have mobility on the coronal third, you need to be able to assess that from a restorative point of view and a periodontal point of view. If you don't think you'll be able to get any kind of reattachment of that coronal segment, you have to start thinking about other options there. That's not a good situation. I saw a hand? Okay. Sure. Now, even after we do that, we treat the coronal segment. Even after we do that, sometimes it just doesn't heal. I would venture to say that MTA would have been a better place to approach this. But sometimes it won't heal, and you'll end up with a persistent infection there. What you can do is lay a flap and open up that area around the apical fragment. Now, again, because it's not horizontal, it's more oblique, sometimes you have to remove a little bit more bone in order to get that apical fragment out of there. Once you take that apical fragment out, then you want to try to put some type of restoration into the tip of the root. MTA would be a good choice. You don't want to use amalgam in that area because it would cause discoloration for the tissues over top of that. And in this case, the apical fragment was removed, MTA was placed in here, and there was some resorption on the adjacent tooth that was cleaned out, and at that time, back in 1981, amalgam was placed in there. And here we are several months later with good bone fill apically where you didn't have it before. So that's a really nice result. Here's another case where there was a horizontal root fracture here, and it formed a calcific barrier there. But the patient persisted to have an infection apically. This is a case where the apical fragment did go non-vital. This case was treated coronally, filled up with gutta percha vertically, and then a flap was laid, and the tip of the root was actually instrumented with conventional endodontic files, And in 1983, this was filled with amalgam apically. It can work. You can keep the tooth. Some people might look at something like this and say, let's pull it and put an implant in there. This was a young patient of low socioeconomic means, and this was a nice way for them to be able to keep that tooth with good healing a year later. Don't do this. There's a temptation to try to do a splinting between the two fragments. We're dentists. We always want to try to put things together. You will have 0% success rate because where it's going to break down is in this area here. You will not be able to get a decent seal apically or where the fracture site is. Don't try to do an intraradicular splint. It will not work. Sequelae and complications. Sometimes you can get a tremendous amount of calcification forming in that coronal piece. That's okay, but it usually makes the tooth very, very yellow. So the patient needs to be informed that that might be a possible sequela to that. Sometimes here's a fracture here. Sometimes you'll see a reaction of the pulp tissue where it grows and grows. That's an internal resorption. And that's not a good thing either. You want to get that pulp out of there before you lose the tooth itself. And sometimes the body just says, hey, we don't like this, and it dissolves away the root of the tooth. Again, not an unusual complication, external resorption on a tooth that has had a horizontal root fracture. So remember, typically these horizontal root fracture teeth remain vital. Typically, if the coronal fragment becomes non-vital, the apical fragment tends to remain vital. For pediatric considerations, you're going to see cases like this where there may be a horizontal root fracture on a primary tooth. Leave it alone. It will tend to resorb just like the natural root would, and you don't want to do anything traumatic in there that may ultimately affect the tooth bud underneath of that. Any questions on intraalveolar root fractures? It's a pretty neat topic. Yes?
This is sort of related, but for internal root resorption, if there's been a traumatic injury, is there like a range of time, how many years out, one can start to see symptoms, or is it completely generic?
There's a couple-part question here. She wanted to know that in a case where there's a traumatic injury, when there is internal resorption, is there a time frame of when it's going to happen or when the symptoms are going to be? No, there's none. It's a whole gamut. I'll see somebody that has internal resorption and they'll say, yes, I was in a car accident on that tooth 20 years ago or last year. It's really variable. There's no magic answer. And then in a case like that where it's 20 years after an accident, is it something that happened 6 months ago and we don't know about? Internal resorption is really difficult because a lot of times, especially if it's on a molar area, it can severely compromise a tooth and make it so the tooth is not restorable at all, both endodontically and restoratively. So that's why I'm a big proponent for full mouth series. Every 5 years, I don't think it would be all that unreasonable. Other questions on intraalveolar root fractures? Do we need a break or can I cruise along? I'm getting to go. We're going to talk about crown root fractures. It's a type of intraalveolar root fractures, and I got a really good case that'll wake you up a little bit. On a case we talked about earlier where there might be a root fracture that's in the coronal third and you've lost that coronal piece, you do have the option, shy of an implant, of doing endodontics and orthodontically extruding the tooth. I know, today it would be easier, just take it out and put an implant in there. But this is an option that we can go with. Orthodontic extrusion works great when you're trying to restore a tooth that's broken down like that. And then you have these cases where the tooth is broken off way below the level of the gingival margin, but was really important for this particular German Shepherd to keep this tooth because it was very expensive to train these dogs, these police dogs. So we went in and did electrosurgery. Now, keeping in mind, this was back in the early 90s. The veterinary dentistry was really at its infancy, and it wasn't like we were going into the wrong turf, even though we were. Can I lose my license over this? So, anyhow, there wasn't anybody to be able to take care of this, and the veterinarian brought me in and a prosthodontist in. We did the electrosurge, laid a little bit of a flap, did the endo on the tooth. created a tooth out of wax and Duralay. Sweet. Isn't that nice? This is a very scary dog. So crown root fractures are something that are really difficult to manage, and it depends on your assessment on the endodontics and the restorative prognosis of that particular tooth. There's not much else to talk about on intraalveolar root fractures, crown root fractures. I have a whole hour and a half on vertical root fractures that you don't want to hear today, so I want to keep this tied just to trauma. I'm going to cruise along. Are we okay? Okay, good. Got it all right. On luxation injuries. A luxation is when the tooth is hit and the tooth has moved. It's as simple as that. Displacement of the tooth from the bone. Displacement might not be visible. There's potential injury to the periodontal ligament and the pulpal neurovascular supply. And the injury is dependent upon the force and the direction of that trauma. It encompasses, depending on who you read, between 22 and 61% of all dental injuries. Central incisors are most popular. Severe luxations have the worst complications than minor luxations. We can have resorption, extensive canal calcification, necrosis of the pulp, which is very significant when we're looking at immature teeth. The types of luxations are concussions, subluxations, lateral luxations. With the lateral luxation, it means the tooth has been moved out of the socket. And sometimes the apex can be dislocated with that luxation. Sometimes it's just like a hinge, and the apex stays exactly where it was before with no apical displacement. You can have an extrusion of the tooth itself, or you can have an intrusion luxation. From mild to severe, with intrusive luxations being the worst. Vitality tests, like I told you before, in a case where there's a traumatic injury, sometimes you're not going to get a good response, an accurate response, until a couple of months. But the treatment, in the most general terms, is to reposition the tooth, do endodontic treatment if necessary, and we'll talk about that because it depends on the severity of the injury itself. Concussion, it's just, I got a nudge, it was an elbow. No abnormal loosening or displacement of the tooth in the socket. Typically a questionable injury. They're not even sure if something really happened. It's very mild. Typically there's little. And the management is take some x-rays just to check to see if there's any cracks or fractures. Do pulp testing to get a baseline if you can. And usually no endodontics is necessary for concussion injuries. You okay on that? Just a simple little elbow in gym class. A subluxation is with an abnormal loosening but without the displacement of the tooth. So you have a tooth that had an abnormal loosening with not necessarily the displacement of the tooth. Usually they stay vital. Usually that's not a problem. But sometimes they do become non-vital, and when that happens, you get that dark gray-brown look to it. You need endo on this tooth, and most of the time that can be bleached out with internal bleaching. On lateral luxations, the tooth is displaced labially, lingually, distally, or mesially. In any direction, the tooth is actually moved. If it has, if it's with an apical displacement, that apex is being displaced in the bone, sometimes trapped in the bone, and it causes an interruption to the neurovasculature of the pulp. So those are the cases that tend to become non-vital. A better prognosis without that apical displacement. And the prognosis really depends just on that apical displacement. So if you have a, here we are with an apical displacement where the tooth is out on the buccal bone, labial bone, and here we are where the tooth has been pushed out labially, and the apex stays more or less where it's supposed to be, with maybe just a little bit of alveolar bone fracture there. Apical displacement and no apical displacement. In a case like this where you have an apical displacement, usually the tooth is displaced palatally and the tip of the root is engaged and locked into the bone. It's usually solid, and when you percuss it, it gives you that thump kind of a sound because it's now fused to the bone. It's a dull, metallic sound on percussion. The apex is wedged into the cortical plate. Radiographically, sometimes you'll see a widened periodontal ligament. To manage this, that's locked. The root of the tooth is locked in bone. So you want to pull the tooth down ever so slightly. You'll know it. Push the tooth back out to a normal position, and then replant that tooth back into the original socket, getting in a good arch alignment with the adjacent teeth. You'll probably have to splint that in place. If you splinted that, how long would you splint it for? This is not an avulsion. This is a displaced tooth where you have an alveolar fracture, if you will. When you have an alveolar fracture, you want to splint for 6 to 8 weeks. And that's how long you would splint this for. A loose splint would be better. And then follow up the vitality. Generally speaking, when the apex is displaced and wedged in the bone, you've compromised the pulp, and generally speaking, they go non-vital. If it's an immature tooth, there's a lot of pulp in there, and a lot of times that can revascularize a little bit. So keep an eye on the radiographic development of the root of the tooth, and you'll be in pretty good shape. This case was fortunate in that he already had some braces on there. The tooth was repositioned in place, looking pretty good. The tooth became non-vital, but that might have been a tooth that was avulsed if the braces weren't in place. Then you can have a lateral luxation where the apex is not displaced. You've only cracked a little bit of bone. In these cases, the tooth would naturally be a little bit more mobile than what I showed you before. It's easier to reposition those cases, and typically there's some bleeding in the sulcus because look what happened. You've got a disruption there in the sulcus and in the bone. If percussed, it's usually a pretty normal sound, and usually the PDL looks pretty much within normal limits. Hasn't been displaced that much. And because of that, the pulp vitality, because this is not compromised up here, the pulp vitality usually stays pretty much vital. So to reposition this, you just push it back into the arch alignment, push the tooth into the socket if it's out of the socket, and splint it. And again, because of the micro cracks or the cracks that you'll have in the surrounding bone, you want to splint that for 6 to 8 weeks. Follow up the vitality. You might be in pretty good shape in a tooth like that. But again, on an immature tooth, follow it up radiographically to make sure that the root of the tooth is developing the same way as the adjacent teeth are. Here we are. The tooth has been pushed back. You push that back into alignment and splint it. This tooth had no apical displacement, but the tooth became non-vital anyhow. So you got to follow these things up. Extrusive luxations, it's a displacement of the incisal in the incisal direction. Sometimes there's a little lateral too, but basically the tooth looks like it's longer than the rest of the teeth also. Typically you'll see some sulcular bleeding. You want to get a careful evaluation to make sure that there's not a horizontal root fracture, which would also cause that tooth to look a little bit elongated. It may look like there's periapical pathology on a tooth that's had an extrusive luxation. The reason for that is because now you've got a space of bone at the tip of the root of the tooth where there's no root. So it looks like there's a lesion. A lesion's not going to develop in a day. Okay? It's going to take a long time for that to happen. So obviously that would be an extrusive luxation. And then in a case like that where it appears to be a little bit longer, you just kind of push it back into place. You reposition it and splint as necessary and follow up on vitality. On a mature tooth, you may end up needing a root canal, but if it's an immature tooth, as best you can, you want to hold off on the endodontics and follow it up radiographically to make sure that the pulp and root development is similar to the adjacent teeth. You can actually stretch that pulp tissue about 2 or 3 millimeters without it breaking off and compromising the vasculature. So you might be okay on some of these extrusive injuries. Intrusive injuries, they're pretty bad. That's when the root of the tooth has been displaced up into the apex of the tooth. Questionable spontaneous eruption if more than 3 millimeters on an immature tooth. What that means is it might not erupt by itself. Surgical repositioning is advised for the mature teeth because a lot of times what will happen is on a mature tooth is it will be wedged up into the bone. The bone says, hey, we don't like this root of the tooth, and the bone starts to grow into the root of the tooth, causing a replacement resorption that we talked about, ankylosis, and you won't be able to get that tooth back down again. So a lot of times what they recommend is to surgically get your forceps out and pull the tooth back down to a normal position and splint that in place. You get a severe periodontal ligament compression, therefore there's a higher incidence of replacement resorption. You're compromising the blood flow in the PDL, so you're increasing the possibility of external resorption. It's a worse prognosis of all the luxation injuries. Here we are here, where this tooth was up there, and if you notice, right here, there's not a lot of root. That's because the bone has infiltrated into the root of the tooth, causing that root to be locked in place. Not a good situation. Here's a case here that was sent over. It was an immature root of a tooth, and the patient was originally sent to the oral surgeon to get the, quote, fractured pieces of tooth out of the gum. They just assumed the tooth had broken off. When it was cleaned up real well and a radiograph was taken, we could see that there were certainly roots there, and roots that, although it's hard to tell on the radiograph, they're not formed all the way. We elected to monitor this patient very carefully, and on follow-up, they extruded all by themselves. That's a really nice result, and the patient did not need endodontic treatment. So for a mature apex, you want to consider surgical repositioning of the root of the tooth, like that, putting it in place and splinting it. A note on splinting. We like wire and a little bit of composite. That's like our ideal endodontic splint. However, there's a temptation to slop a bunch of composite in there. Try to avoid that, but I certainly understand that in an emergency situation where your spouse is waiting for you for dinner, you may want to just put some composite on there. If you do that, it'll be okay. We like to see a more loose splint, but if you've got an extra 30 seconds before you put your composite on there, break out your die-cal and put some die-cal into your embrasure space. Give it another minute, let it set up, and then put your composite on there. That way your composite will not go into that embrasure space and be impossible to remove later. So just a little trick there if you decide to splint it in that particular way. On splinting, if there's no or minimal alveolar fracture, you can just splint it for 2 weeks. But if there is an alveolar fracture, like on these luxation injuries that I talked about, you want to splint it to 4, 6 to 8 weeks. Non-rigid split is preferred. A thin wire with composite is preferred. It's been advocated, especially on avulsions, and we'll talk about that later, to have a little bit more movement in the tooth. So you can take some 20 to 30 pound fishing line in your office and wrap that around the teeth and put composite blebs on the teeth. It allows the teeth to move a little bit more, and it's actually been shown in studies using animals that you have less resorption in these types of cases. And we're in Annapolis, so there's a lot of fishing line around there. And again, this is the fishing line with some composite on there. And this is where the composite is bridged between the teeth. Tempting, but again, put some die-cal in between that, which you'll be able to allow you to get that composite off there later. There's different types of ribbons and fibers that are available that can also assist you with splinting. Possible sequela to luxations, of course, necrosis. We have the non-vital tooth there. You can have a hypercalcification, which we get, which will cause what? It'll cause the tooth to become very yellow, but it does not necessarily mean that it needs to have endodontic treatment. It usually causes the tooth to become more yellow, maybe a little bit gray, but not that brown gray that you get from a non-vital tooth. These cases are sent over every now and then. Please do a root canal and bleach the tooth. They're yellow because of the hypercalcification, and no matter what I do, it won't lighten it up. Watch out for resorption changes, both internal resorption and external resorption. This is, again, internal resorption right around there. I'm going to talk a little bit more on external resorption when I talk about avulsions, because that's where it really comes into play. Let's talk a little bit about resorption since we had some questions over there earlier. External resorption moves with the radiographic angle, and you can see the canal space with dissolved root around it. Okay, it's not an incontinuity in the canal space itself. So if you have a case like this where you have some external resorption, you can see the canal space through that. Although it's in the middle of the tooth, that's not internal resorption. You can see the canal space, and if you take that at a different angulation, you can see that the resorptive lesion actually moves. Okay, that's external resorption. Internal resorption stays where it is, and it's relatively symmetrical with the canal space. So if you have a case where you have an internal resorption lesion, again, you don't see the canal running through there, you see a balloon inside of a pipe, and if you take it at a totally different angle, you'll see that there also. No canal space, and it's symmetrical on various angulations. It's an internal resorption. And endodontic treatment works very, very well for that. Any questions on luxation injuries? Yes?
I noticed that when you splinted the teeth, you used the splint on the labial as opposed to the lingual. Is it one preferable to the other?
The question is splinting on the labial as opposed to splinting on the lingual. I don't have a preference. I think I'd have a tougher time doing it on the lingual, but it won't make that much of a difference. I mean, I'm an endodontist. I mean, composite in my hands are like, we don't want to go there. Yeah? A monofilament line. Excellent question. Other questions on that line? Are we still okay? We're moving along. You guys, it's 73 degrees out there, 70% humidity. We're doing great. Okay. Avulsions. So we have avulsions, and then after I'm done with avulsions, we're going to touch just a little bit on prevention and mouth guards. And then we're done, and we're done early. Is that okay? Are we okay with that? Okay, good. You know, when I was like in 3rd grade, I remember I ran for class president, 3rd grade. My father was like this marketing genius, and he had this whole speech that he wanted me to say. But he said when I started off the speech, now I was in 3rd grade, so I was young. We did have we did have electricity then, but I told my mom, I said, Mom, this is what I'm going to say. This is what Dad told me to say. He said, go up there and say this. Say, I'm going to give you a speech because I'm running for president of student council, and my speech will be like a girl's dress, short enough to attract attention, but long enough to cover the subject. I thought my mother was going to kill my father. So she was way ahead of her time, and he, I guess, was still stuck back there. Anyhow, well, I won't say that, but I'll just kind of keep this a little bit shorter. And as long as we're talking over on this side of the room, does anybody know what this looks like? No. Well, she said crack pipe. I mean, it might have been a pipe to smoke. So are we still on video? Anyhow, avulsions. You guys, a tough crowd here. Avulsions are when a tooth gets knocked out. It's when the tooth is completely knocked out of the socket. The stats are this. The incidence of avulsions are about 1 to 16% of all dental traumas. Happens a lot. It most commonly happens to maxillary central incisors for obvious reasons. It's most common in 7 to 10-year-old kids. Again, they have a lot of overjet. They're starting to ride their bikes for the first time. They're getting a lot more active. That's not that unusual of a stat there. The successful healing percentages, there's an expression, statistics don't lie, but liars use statistics. It's really hard to put a good stat to the success rate on a tooth that's been knocked out of the mouth because there's so many different parameters that are involved. It's really variable. You have trauma to the pulp vascularity, you have trauma to the pulp innervation, and you have trauma to the periodontal ligament and the surrounding bone. So there's a lot of variables as far as the type of injury that you have. But the International Association of Dental Traumatology has put out this great chart with cartoons on it, and it's in English. I've seen these in school offices and stuff, and yeah. Anyhow, what's important is how long this tooth has been out of the socket, what storage medium that tooth has been in when it got knocked out, the splinting type and the duration of that splint, how that root has been manipulated when it was out of the mouth and in your office, and the tooth maturation. All of those are really significant factors that will end up addressing how you manage the tooth and what the future success rate is going to be for that particular tooth. But the most significant factor, if you had to put it all together, the most significant factor having to do with the prognosis for a tooth that's knocked out is the management of the periodontal ligament. When a tooth is knocked out of the mouth, most of the PDL that holds that in place goes with the tooth. Some of the PDL actually stays in the surrounding bone, but most of it's on the tooth. And unfortunately, if you don't manage the root of the tooth well, you're going to have dead cells in that PDL that's on the root of the tooth. They're not going to come back alive, and that's when you're going to have a poor prognosis. So everything I'm going to talk about having to do with the prognosis for a tooth that's avulsed has to do with managing, keeping the PDL alive. The basics are, you have a mature tooth. If it's avulsed, you put it back into the socket, and we'll talk about that. They're going to be non-vital. There's no way it's going to revascularize. Just figure you got to do it. It's not one of these wait and sees, because if you wait and see what I've got for you. It's a real mess. You don't want that. An immature tooth, you can possibly get some revascularization. It might not be pulp tissue, but an immature tooth, especially one that's really wide open, take the chance. And if you can get some mileage out of it, maybe if for nothing else, to allow that tooth to last until the patient's in their late teens, that's what you're hoping for. But do your best to reimplant that if it's an immature apex. And you want to reimplant as soon as possible. So that's the basics here. The primary prognosis determinant is root care. Maintaining the periodontal ligament vitality is the main thing. The PDL mostly remains on the root surface and less in the socket, like I just said. And what contributes to a poor prognosis is if the root is dry, if the root is manipulated, and the sequela of that is the body says, I don't like that root. And it eats away on that root of the tooth, either with an inflammatory resorption or replacing the root of the tooth with bone, ankylosis, or replacement resorption, we would call it. The time out of the socket is really important. If it's dry, less than about an hour, you're going to get a fairly good prognosis. If you bring that root into your office and you say, well, let's just soak it in some saline to kind of moisten it up a little bit, the studies show it doesn't make any difference at all. If the tooth is wet as opposed to dry, with the proper storage medium, you can get some good mileage out of that periodontal ligament, sometimes 3 to 4 hours, and get a pretty good prognosis if it's stored correctly before you put it back in the socket. It's obviously optimal if it's wet, and less optimal and less than an hour. So the shorter period of time, the less time it's out of the socket, and the more that it's wet with something that's a good storage medium, the better your prognosis is going to be. Transport medium. Obviously, the socket is the best place to transport this tooth. So if you can, and if the parent can get the tooth back into the socket, that's the best place to put it. But I understand it's really tough, especially when it's your own kid. They do make some specialized containers that some of the emergency rooms have, and some of the schools have also. Yes?
What about milk? Is that an old wives' tale? I've heard that several times.
Is it wise tale or wives' tale?
Wives' tale.
Okay, we'll talk about. I'm not sure. It's like a deer in headlights.
Yes.
Right. Anyhow, I'll go over that with you, I promise. Specialized containers. These containers have a buffered saline. It's the same osmolarity, and it allows these PDL ligaments to stay alive. So these specialized containers are really very good. And it's possible, according to the studies that are done, to keep the periodontal ligament alive for 12 to 24 hours. And they seem to work pretty well. So if you're in a place where they have these specialized containers, sometimes they'll put them in these containers before it goes to the dental office, and it works very well. There's a company called Save-A-Tooth, and they have these cute little baskets that you can put it in. There's one called DentoSave. These are out there, and they should be at the schools. So if you're a dentist and you want to try to market your practice a little bit, you can get these. You can slap your names on them and your phone numbers and take them to the schools. They'll love you. Milk. It's not the calcium in the milk that makes it so good. It has the same osmolarity as the PDL. It allows it to stay alive really well. It's possible to keep the PDL alive in milk for about 3 hours. Actually, some of the studies showed that the PDL remains alive for about 12 hours if it's stored in milk. Skim, low fat, lactate, cold, it doesn't make any difference. It's the osmolarity of this stuff that really makes the big difference, and it works really well. Propolis. Anybody ever use propolis? You know what that is? Beehive honey, purified bee honey. It's in some of the cosmetics that are out there. Nothing can grow on this stuff. It's antibacterial. And there have been some studies to show that propolis actually works really well, probably better than milk, in keeping the PDL alive. They use that on ulcerations also, to allow ulcerations to heal. It's honey, it's natural, and it works really well, and it does come medical grade. Coconut milk has also been out there and has been tested, but unless you're on some tropical island, chances are milk is probably more accessible. People have talked about putting it in the vestibule of your mouth. I'm not sure how those studies were done, but it only shows that about 30% of those cells remain vital after about 30 minutes. So it's good, it's wet, but it's not ideal. Try to get the tooth back into the socket as best you can. In office management, the patient comes into your office. Yes?
How about water?
The question is, how about water if all else fails? Well, it's wet, but it does not have a good osmolarity. If you don't have anything other than water, it's not the end of the day. But if you took some water, like an 8-ounce glass of water, and put a level teaspoon of salt in there, that's more or less like normal saline. In the office, patient comes in, you assess the patient like we talked about earlier, you irrigate the root with saline or Hank's balanced salt solution. Don't manipulate the root of the tooth. Keep your hands off the root of the tooth. Just wash it off with saline because there may be some dirt or some particles that are on there. Irrigate the socket. Don't curette the socket. Now why? Some of the PDL is still in the socket. So you don't want to do anything to disturb that. So what you can do is go in with an irrigation needle and irrigate out the socket and then replant the tooth. And again, the concept is most of the periodontal ligament is on the root of the tooth, but some of it does stay in the socket. So what you want to do is irrigate that socket because it takes a couple of hours for a clot to form in there, and you might have a problem putting that tooth back into the socket if there is one. Irrigate it out. If there's an alveolar fracture such that it's impeding your ability to get that root back into the socket, go in there with a large Oregon spoon excavator and just kind of push the socket back out. But don't curette the socket. Put the tooth back into the socket. Your best bet is to get the patient numb for it. Because if you haven't, well, you don't have to. But if you can get that patient anesthetized before you do that, you'll be able to push it back to where you want it to go. And who's the best person to push that tooth back into the socket? The patient. The patient. Because they're going to push harder than you will and harder than the mom will. So they're more inclined to push that back up into shape, and you're realizing that you're not really hurting the patient that way. So push that tooth up there. It's a slow push because there's a lot of blood up in that area and a lot of hydraulics going on in there. Put that back into place, and once it's back into position and you've got decent arch alignment, you might want to have them bite down on some gauze just to make sure it's in there. But be careful. If they're biting down on gauze, and if there's any alveolar fracture on the buccal, there may be a tendency to push the tooth out towards the buccal. So put it in place, dry the tooth off, and splint it. You want some physiologic movement to the root of the tooth when it's splinted. And you want to remove that splint within about a week to 10 days. Or you get an increased amount of replacement resorption. So if the tooth is moving a little bit because you have composite blebs on the teeth and either a very thin ortho wire or monofilament line, the tooth will have a little bit of flexing. The sturdier that splint is, the studies show the higher the incidence of replacement resorption. And getting it off of there within 10 days, as long as there's no significant alveolar fracture, that makes sense too. So the splinting is a big part of the decreasing the possibility of replacement resorption. Yes? The question was, why does heavy splinting increase the incidence of replacement resorption? I'm not real sure. And I don't know that the studies that were out there really addressed the why. But they do show in animal studies that there is a lot more replacement resorption if it's a heavier splint and left on there for a longer period of time in cases of avulsions. I can make something up, but that wouldn't serve you very well. Yes? Say it again? Would you remove the splint if the tooth is that mobile? You know, with a loose splint and a light wire, sometimes you can actually feel the mobility of that. And if it feels significant to you, say back and forth more than like a couple of millimeters, no, leave the splint on there. Because the reason why you would have that much mobility is if there was any kind of alveolar fracture associated with it that was significant. And if that were the case, you'd want to leave it on there for a couple of months. The maximum you want to leave the splint on there? You would want to leave the splint on an avulsed tooth 7 to 10 days if there was a lot of mobility to it, either before you take the splint off or after you take the splint off. Leave it on there for another 6 weeks. Okay, that would be the splinting of an alveolar fracture. Sure. So here we are with a monofilament line stretching between the teeth, and then you can put composite blebs over top of that. It's a nylon fiber and a composite with some movement that you're going to get. Leave it on there 7 to 10 days. So here we are again. And it's hard. It's hard to splint these things. The lips are bleeding. The patient's not happy. Sometimes that's the best you can do, and that's okay. And again, if you notice here, there is some dical between the teeth so that the composites don't go interproximally. Try to avoid the circumferential wiring. The oral surgeons like this a lot, but there's a tendency for the tooth to actually be extruded out of the socket a little bit more when you do this type of splinting. Orthodontic brackets have been proposed for doing this also. It's actually really easy, but you would have to have those brackets already on a wire, bend the wire to the arch configuration, and then bond it to it. It's a nice way to go, but we certainly don't have orthodontic brackets in our office in a wire. I'm not even sure what an orthodontic bracket looks like anymore. But you may have these in the office, and if you can do that, that's fine. But the easiest thing is a light wire and some composite. There are meshes that are out there, but they tend to be really messy to work with, and they're really hard to remove, and they're very rigid. Now, on avulsions, let's look at this and address this having to do with whether it's an immature apex or a mature apex, and whether it's wet or dry, and the time that it's out of the socket. Those are all the important variables. On an immature apex, there is a possibility, according to the literature, about 20 to 40% of these will actually revascularize with an osteodentin type of material in place of the pulp. And that's okay. Here's a case here where this tooth was avulsed, and it actually remained vital, and again, is inflamed inside there, so you'll notice that the canal space is much more constricted because of that. Most of that material, if you looked at it histologically, is a osteodentin. There were some studies that tried to use mincycline to put on the root surface, hoping that it would decrease the amount of resorption. The studies were really mixed. I think you're better off not wasting your time and just putting that tooth back into the socket again. Here's an immature apex. And again, if that looks different to you than what a normal tooth should look like, you're right, because that's not pulp tissue. It's kind of an ingrowth of bone, and if you looked at it histologically, you'd see some dentin tubules in there also. But it's stable, and it's there. It doesn't look like normal pulp tissue, but a little bit of dentin kind of mixed in there with it. But if you had a child who's 13 years old with a wide open apex like that, you know, how old can you be before you put that implant in there? 18, 19? I mean, you don't want to do it much sooner than that. So if you can get some mileage out of this and make sure the parents are aware that that's probably all the mileage you're going to get out of it, then that's pretty good. We talked a little bit about pulpal regeneration. In a case like this, from a traumatic injury, where you had a wide open apex and a lot of bone in that area, it looks pretty hopeless. And again, what we've done is taken cases like this, removed the necrotic pulp that's inside there, irrigated it with disinfectants, put a couple of different antibiotic pastes in there to make sure it's really disinfected, bring the patient in after it's been sealed in there, and then fill up the top part of the tooth with MTA. MTA against blood will form a barrier and get differentiation of material, and they're calling that pulpal regeneration. Now, the reason why they're not saying it's just a growth of bony type of stuff in there is because look at the constriction of this canal and the formation of the root of the tooth compared to here. It's actually doing something. So it's not pulp, but it's close enough to it, and it allows those Hertwig's root sheets to actually continue to develop. So there is some really good studies being done with this, and it's a a big push in endodontics to go down the research line as far as that goes. Okay, so if it's an immature apex and if it's dry, it's the worst prognosis if it's greater than an hour. And then we talk about different apexification options like we talked about before. But you have an immature tooth with a ton of pulp in there and it's been dry for more than an hour, you got a pretty poor prognosis there. And the only thing you can do right in a case like this is to inform the parents that this is not going to be a great case. Follow it up and you'll do an apexification. But if it's a mature apex, the endodontic management is very, very particular. Assume that that tooth that's avulsed is non-vital. It will not grow new normal pulp. You want to get that pulp out of there in 7 to 10 days. And don't do any treatment on the tooth, but you want to wait at least a week before you go into it. To back up, pulp is non-vital. You don't want to do any treatment for about a week. It takes about 7 to 10 days, 2 weeks or so, for the periodontal ligament to actually reattach to the root of the tooth. That's verified by some very good studies. That's why you can take that splint off of there in 2 weeks, because it takes about 2 weeks for that PDL to actually reattach. Traditionally, what's been done after we go inside the tooth is to put calcium hydroxide paste inside the root of the tooth. This is after a week. You enter the tooth, you put calcium hydroxide in there, and wash that out several times over the course of a few months. Because it was thought that by putting calcium hydroxide up inside that pulp canal space, that it would decrease the incidence of root resorption. Well, the studies haven't really shown that. It's still recommended, but it probably doesn't make that much of a difference as far as putting the calcium hydroxide inside there. The studies now show that calcium hydroxide probably not necessary for more than 7 to 10 days prior to your obturation, unless you see early signs of resorption, because there's a tendency for that to slow down the resorption just a little bit, and then you obturate the canal. So let's back up a little bit. You don't do anything except splint it. You're going to leave the splint on there for about a week. Around that time, right before you take that splint off, you're going to do endodontic treatment. You access the tooth, you clean out the pulp, you put calcium hydroxide in there for about a week. Bring the patient back in and obturate it. Are we clear on that? And here's a reason for that time frame. It's very specific. If this is your tooth in your bone, and if this is the PDL, you can see those little red stripes there. When the tooth is avulsed, that periodontal ligament becomes separated from the root of the tooth. So there's a discontinuity in your periodontal ligament, some with the root of the tooth and some with the bone. If you go in there at that point before that PDL is reattached and you fill that with calcium hydroxide or your root canal cement, it will go beyond the root of the tooth and it will destroy the periodontal ligament that's around there. And you don't want that, because when you lose the periodontal ligament, you're going to get a lot of resorption there, and that's bad. So you don't put any medicaments inside there, calcium hydroxide or anything, until about a week, and while it's splinted. If it's dry and out of the socket for more than an hour, assume that there's no viable PDL and you have a poor prognosis. The treatment's controversial. Some authors have said to scrape off the remaining PDL and soak it in fluoride for 5 minutes, or even Emdogain, but the prognosis regardless is fair to poor. Consider not replanting it. Here's, again, another picture of replacement resorption where this is a sequela to an avulsion where the bone has actually replaced the root of the tooth. Inflammatory resorption is when the root of the tooth has a rapid dissolving of the root of the tooth. You see that? This was out of the mouth for a very long period of time, and there's no way that that's going to heal, and the body says, hey, we don't like you and you're gone, and it eats away the entire root of the tooth. As long as we're talking resorption, we'll talk about cervical resorption, also called cervical invasive external resorption. It's a big problem because what it does is it eats away the root of the tooth there. How are you going to manage that? You can probe down in there on the labial surface and you can get way underneath the gingiva and you still have a big hole in the root of the tooth. What are you going to do? Is this tooth salvageable? Consider endo, orthodontic root extrusion. Consider pulling the tooth, consider flapping it and putting some Gerastore in there, which can get a connective tissue reattachment after it's closed over. One way or the other, this is not good, especially in an area where cosmetics are an issue. If you have this cervical resorption and you're not catching it until later in the game, assume that it's not going to give you a great result, no matter what you do, if it's bad enough. There are some heroics, you might be able to get some mileage out of it, but the patients need to understand that when you have a cervical invasive external root resorption there, especially when it goes below the crestal bone, that whatever you do, chances are it's not going to improve the situation, whether you're grafting, putting Gerastore there, or whatever. It's not a good situation because, I don't know if there's any periodontists in here. If anybody knows how to grow crestal bone back, please let me know. Primary tooth considerations. On primary teeth, don't replant them. Now, antibiotics, I didn't mean to gloss over that. Primary teeth, do not replant an avulsed tooth because it could feasibly damage the tooth structure underneath of that. Antibiotics are probably a good idea because we're dealing in a dirty environment. And there have been some studies to suggest that in cases like this, that penicillin decreases the amount of external root resorption. Doxycycline twice a day for a week. There's been some studies to show that that might be favorable too. But again, you don't want to give any of the tetracyclines to pregnant women. Informed consent, very important. Patients, their guardians, what have you, they need to know that this is not a good situation. And like I said, statistics don't lie, but liars use statistics. You're not going to be able to tell them if this tooth is going to be around a year from now or 10 or 20 years from now. They need to know that they're in a compromised situation, so their expectations are low, and hopefully you'll be the hero and get a lot more mileage out of this. Follow up, follow up, follow up. Make sure that you follow up these teeth for resorption, for pain, for swelling, for sinus tract, and also the adjacent teeth there too, to make sure there's no problems with any of those. X-rays are your best friends for things like this. And again, the vitality of the adjacent teeth, very important. Questions on avulsions. It's an important topic.
One thing, ask them to start putting their evaluation forms together so we can look those soon.
All right. You're in a room. It's almost time to leave. You need to do everything you possibly can in order to get out of the room on time and not have anybody yell at you. Fill out those little pink sheets that have been passed around, and that way nobody will yell at you. I've got one more thing to talk about. We'll make it really quick. Two more things. I'm sorry. Soft tissue management. There's some cool stuff that's out there for lacerations like this. Crazy glue, cyanoacrylate. There's medical grade that you can use to help hold these together. They work very, very well. Dry it off, put the cyanoacrylate in there, and it can actually close these things off really nice, and it's great for hemostasis. Look for foreign objects in the soft tissue. Sometimes what you can do is put an x-ray in front of the tooth and take an x-ray to see if there's any kind of stuff inside the lip itself. And sometimes you'll see some little particulate matter inside there. And as far as prevention goes, you guys will know more about this than I do. As far as the boil and bite mouth guards, they're good, they're quick, they're easy, but it doesn't give you a great adaptation to the root of the tooth. You need to have something that's about 2 or 3 millimeters thick with really good adaptation to the teeth themselves. The kids will wear it, they'll wear it easier, and it's pretty easy to do. You take impressions, they do a fabrication in the lab, you trim it, polish it, and do any kind of occlusal equilibration that might be necessary. There's some great vacuum form mouth guards that you can make. Probably have the stuff already in your offices, and they work really well. The thickness and adaptation is a problem, so you're better off using the equipment, and a lot of times the lab has it that has pressure that's placed on those mouth guards, so you can put 2 layers of the EVA in there and get a positive pressure and get excellent adaptation to the teeth. So your impressions are given, you mark off to the lab where you want it to go as far as the mouth guard goes. They have a suck down technique with positive pressure on top of that, and then a heated knife to actually carve that away at the lines that you've created, and you end up with a really nice, well-fitting mouth guard. It's a tremendous service, but I know it's a pain because these kids, they grow like by the month, and especially for the young ones that are in a mixed dentition, but it's a nice way to go. And they have all different kinds of cool colors and shapes that you can use also. Any questions on prevention? Yeah. Don't the drugstores have those Yeah, don't the drugstores have those things? Yeah, they're called boil and bite mouth guards, and they do have them, but they're not very good. The adaptation's not very good. And the kids don't tend to wear them, and a lot of times they end up being on the side of the mouth because they know they're supposed to be wearing them. If you get the ones that adapt really well that you can make in the labs, they'll wear them, they're comfortable, and they'll give you that much more protection.